Just a second, let me tell. Okay, so yesterday we have finished with different receptors which are found in different organs. Okay, and what these receptors do, what type of G protein class receptors these are, we have discussed this. Okay, we have discussed the process of the signaling of these GQ, GS, and GI receptors. Okay, we have discussed where the receptors found, what receptors do in different parts of our body, and today we are going to discuss the autonomic drugs. Okay, so first we start with the formation of or synthesis of this non-epinephrine, epinephrine, and the acetylcholine. Okay, in the biochem section we have already discussed the formation of the. Please turn off your mic. Let me just do it. Okay, so today we're going to discuss about the autonomic drugs, and first we discuss the synthesis of the non-epinephrine and the epinephrine. We have already we discussed this in the biochem section, right? How this tyrosine is formed, the tyrosine, and then the dopamine will form from the tyrosine by the action of enzyme.
Yes.
Anyone remember the name? Enzyme name?
Dopa decarboxylase.
What enzyme? Tyrosine hydroxylase, remember?
Yeah.
And then the dopamine will convert into the, the dopa will convert into the dopamine by the enzyme.
Dopa decarboxylase.
Exactly, dopa decarboxylase. And then this dopamine uses the receptor, which are the VMAT or the vesicular monoamine transporters, okay, to enter into the vesicles. And inside the vesicles, the dopamine will be converted into the non-epinephrine. Anyone remember the enzyme name?
Dopamine beta hydroxylase.
Exactly, dopamine beta hydroxylase. And as a result, and the non-epinephrine is now synthesized. Now, whenever the action potential is generated, this non-epinephrine will go to the end of this end of the terminals, fuses with the membrane, and as a result, all of the non-epinephrine will be secreted in the synaptic cleft. Okay, and once the non-epinephrine is secreted, it will bind to the alpha or the beta receptors. Can anyone remember the receptor name for the non-epinephrine? It is alpha 1, alpha 2, and
alpha 2, beta 1.
Exactly, not the beta 2, right? Okay, and then there are some NET receptors, which are the non-epinephrine transporters. And with the help of this non-epinephrine transporters, the non-epinephrine is reuptaken. Okay, the reuptake of the non-epinephrine will happen with the help of these transporters, and as a result, it will go back into the vesicles inside the neurons, right? And as a result, it will be cleared from the synaptic cleft, or the metabolism of this non-epinephrine will occur. Can anyone remember the enzyme name for the metabolism of epinephrine, non-epinephrine?
Catechomethyltransferase transferase.
COMT.
Okay, yeah, exactly. And what would the product? The product name?
Metanephrine.
Vinyl mandelic acid.
Exactly. Metanephrine, and the normetanephrine, and finally vinyl mandelic acid. Okay, and that's how the non-epinephrine is cleared from the synaptic cleft. Now there are certain drugs which act on these pathway to inhibit them. Okay, and there are certain drugs which will activate these pathways even more. Okay, so first is your drug, which is a tyrosine. Okay, which inhibits the step of converging of this tyrosine to the dopa. Okay, you no longer use this drug anymore, I think. Okay, and earlier this drug were used for the hypertension treatment. Okay, and not anymore. Similarly, the drug which is a reserpine, which inhibits the vesicular monoamine transporters. Okay, and similarly use this drug for the hypertension treatment, but not anymore again, right? And there are certain drugs which inhibits the non-epinephrine transporters. These drug includes the amphetamines, the cocaine, and the tricyclic acid. Just a second. And the TCAs. Okay, the cocaine, the TCAs, and the amphetamines, they inhibit the non-epinephrine transporter, and as a result, the concentration of non-epinephrine in the synaptic cleft would be increased. Okay, and one more thing, once the non-epinephrine is released from the neurons and enters the synaptic cleft, it will give some negative feedback to the alpha 2 receptors. And what is the function of alpha 2 receptors? Remember, I told you that alpha-2 receptors are found in the presynaptic neurons and they will inhibit the release of norepinephrine, right? So norepinephrine gives a negative feedback to the alpha-2 receptors so that they cannot inhibit the release of these norepinephrine's, right? Okay, so so yeah, these three drugs, the cocaine, the TCAs, and the amphetamines, they inhibit the non-epinephrine transmitters. One more important thing for the amphetamines is actually these amphetamines enters inside the neurons, okay, using the NET receptors. Okay, using the NET receptors, the amphetamines enters the neuron, and after entering the neuron, and they will use the VMAT receptors to enter the vesicles. Okay, so now amphetamines enters these vesicles. As a result, the concentration of amphetamines inside the vesicles is increasing, and as a result, the non-epinephrine will be start secreting out of these vesicles, and as a result, and as a result, the non-epinephrine concentration inside the neurons would be increased. So what happened? The amphetamine used the NET receptors to enter the neurons, and then they will use the VMAT receptors to enter the vesicles, and they will kick out the non-epinephrine from the vesicles. Okay, they will replace them. And now as a result, the concentration of non-epinephrine will be increased inside the neurons. Okay, and once the concentration of non-epinephrine increased inside the neurons, what's gonna happen? The release of the non-epinephrine from the neurons would be increased, first thing, and second thing, the uptake of the non-epinephrine through these receptors would be decreased. Okay, so this is the working action of the amphetamines. What does they do? But they will replace a non-epinephrine in the vesicles, and as a result, the concentration of non-epinephrine inside the neurons would be increased inside the free space here, right? And as a result, the secretion of the non-epinephrine, the release of the non-epinephrine from the axons would be increased, okay, and the reuptake of the non-epinephrine through these receptors would be decreased, and as a result, ultimately the concentration of non-epinephrine inside the cleft would be increased. This is a working of the amphetamines, okay. And there is one more drug which is ephedrine. It also increases the release of non-epinephrine, okay, very much important. So amphetamine, ephedrine, cocaine, TCAs, and again the amphetamine, all of them are the sympathomimetic drugs, okay, very much important. Any doubt on this part?
Would you repeat this amphetamine mechanism of action?
Okay, so what does amphetamine gonna do? It will use the NET receptors, which are the non-epinephrine transporters. Using the non-epinephrine transporters, it will enter the axons, okay, then inside the axons, it will use the vesicular monoamine transporters to enter the vesicles, okay, and in the vesicles, the non-epinephrine is there, right? So what's going to happen now? The amphetamine will start replacing the non-epinephrine inside the vesicles, okay, and the non-epinephrine concentration would be increased inside the axons, in the free space inside the axons, okay. And once the concentration of this non-epinephrine is increased inside the axons, it will be start secreting out of the axons, right? That's the first thing. And second thing, the intake of the non-epinephrine from the NET receptors, it would also be decreased because the concentration is already too much inside the axons. So the reuptake would be increased, and secretion or the release of the non-epinephrine would be increased, right? And as a result, ultimately the concentration of non-epinephrine in the synaptic cleft, which is this space, this would be increased, right? And this is the action of the amphetamine in the axons. So amphetamines, the cocaines, the TCA, the ephedrine, all of these drugs are the sympathomimetics, okay, because they increase the sympathetic activity, right? You need to know about the working action of the mechanism of action of the amphetamines, very important. Cocaine, TCA, amphetamines, similarly, they inhibit the non-epinephrine transporter so that the concentration of the non-epinephrine would be increased. Ephedrine causes the increased release of the non-epinephrine from the vesicles, okay, and similarly, it will increase the action of non-epinephrine, okay. Now is it clear?
Okay. Yes. Thank you.
And remember the function of alpha-2 receptors, they gives a negative feedback to the release of non-epinephrine, and as a result, the release of non-epinephrine would be decreased. And that's why I told you the alpha-2 receptors are sympatholytic type receptors. They will decrease a sympathetic response. Okay. Yeah, that's about it. And then comes the acetylcholine. the choline will be intaken inside the axons, and it will combine with the acetyl coenzyme A to form the acetylcholine. The acetylcholine will be entered into the vesicles, and ultimately when the action potential is generated, the calcium influx will occur, and after the calcium influx, finally these vesicles would be fused with the membrane of the axons, and as a result the acetylcholine would be secreted inside the synaptic cleft. That's how the synthesis of the ACH happens. And remember the function of this toxin, the botulinum toxin, what does it do?
It leaves the snare proteins.
Exactly, and the snare proteins are responsible for the fusion of these vesicles with the membrane. Without the snare proteins, the fusion won't happen, and as a result, the release of acetylcholine won't happen, right? And so you will get the inhibition of the ACH release. So both muscarinic as well as the nicotinic symptoms will occur in case of a botulinum toxin. And how does a baby get this toxin? Anyone remember?
From honey spores.
Honey
Spores in the
spores.
honey.
Yeah, good. Exactly. So now any doubt? And yeah, so guys, you can tell me what gonna happen in the toxicity of this cocaine or the amphetamine or the epinephrine, right? You guys can now easily understand. In case of eye, because because the alpha receptors are also in the eye, the beta receptors in the eye. So what is gonna happen is some mydriasis, okay, which is a very light responsive. And why the light responsive mydriasis? What does it mean?
Dilated pupil?
Yeah, you will get the dilated pupil, no doubt, but it is light responsive. Why?
Dilation.
You guys know
during
about the cycloplegic drugs? Cycloplegic drugs, remember? They will inhibit the muscarinic receptors, right? So the meiosis can never be happened. Only you will get is the mydriasis, right? But in case of a sympathetic drugs, what gonna happen? They will stimulate the beta receptors to cause the dilation, right? Sorry, alpha receptors to cause the dilation, right? But the M receptors are still working, okay? Unlike the case of cycloplegic drugs, they inhibit the muscarinic receptor so that the meiosis can never happen. But in case of a sympathomimetic drugs, they will stimulate the alpha receptors so that the mydriasis happen, but meiosis can still happen, right? So it is a light responsive mydriasis, okay? And you will get the sweating, you will get the agitation, you will get the seizures, you will get the anxiety, okay? And because all of the alpha receptors, they causes the vasoconstriction. So whenever a non-epinephrine concentration increase inside the body, what does it gonna do? It will cause the vasoconstriction. And once the vasoconstriction of the cardiac vessels occur, it can lead to the coronary artery vasospasm. So you will get the myocardial infarction. So often the patient with a cocaine toxicity will present you with a chest pain. Why the chest pain? Because of the coronary artery vasospasm. And like I told you, the alpha receptors, they are involved in the platelet aggregation. You will get the increased platelet aggregation, right? And whenever you take this drug intranasally, what gonna happen? The blood vessels inside your nose, and they will, the vasoconstriction of these blood vessels will happen, and as a result, you will get the ischemia. Okay, and ultimately after the ischemia, what you will get is a mucosal atrophy and the nasal septal perforation. So these are the symptoms of the cocaine toxicity. And similarly, if you take the TCAs, if you take the ephedrine, you will get the similar symptoms. Okay, every sympathetic system you will get the symptom, right? The high BP would be there, high heart rate would be there, right? And you will also get a constipation. Why constipation? Because of the loss of motility and the constriction of the sphincters. You will get the constipation in case of a cocaine toxicity. So now you can easily understand why these things are happening. Okay, any doubt?
No.
You understand okay, you understand the light responsive mydriasis now? Okay, what does this thing mean?
Repeat, please, that
Yeah.
one.
Were you just
so let's see.
comparing the light mydriasis in cocaine versus the one you get from like a muscarinic antagonist versus like in muscarinic antagonist you have
Exactly. See, what does a muscarinic receptor do in the eye? Tell me. On the pupil, what does it do?
works on the pupillary muscles to keep them dilated.
Sphincter muscles. Sphincter.
Yeah.
Sorry, Anna.
Constrict
And
sphincters.
yeah, exactly. It will constrict the pupil, right? And once you give the patient anti-muscarinic agents, which are the cycloplegics, what does they do? They will dilate the pupil, not because they're stimulating the alpha receptors, but because they're inhibiting the muscarinic receptors, right? So meiosis can never happen. So what you will get is the mydriasis, right? But in case of a sympathetic agents, they're directly stimulating the alpha receptors. They are not blocking the muscarinic receptors, right? So you will get the mydriasis. But once you shine the light, the muscarinic receptors will be activated, and what you will get is the meiosis, right? Okay, am I audible again?
Yes, sir.
Yes. Yes.
I'm sorry about that. I just lost my internet connection for a second. Okay, see, in case of a cocaine toxicity, if you give the patient beta blockers, then ultimately, because this cocaine, it will increase the release of non-epinephrine, right? So it will stimulate both the alpha receptors as well as the beta receptors, right?
Yeah.
Now, if you give the patient beta blockers, then ultimately only alpha receptors could be stimulated. And if only alpha receptors would be stimulated, what can happen?
Vasoconstriction.
Vasospasms without the vasodilation, because beta receptors are responsible for the vasodilation. So you will get the unopposed vasoconstriction.
Unopposed alpha. Okay.
Exactly. That's why they are contraindicated.
Okay. Thank you. Thank you.
Okay, then the cholinomimetic agents, and these are the agents which mimic the acetylcholine. Okay. And please remember, in case of a muscarinic agonist, if you give the patient muscarinic agonist, what does it gonna do in the lungs? It will cause the bronchoconstrictions, right? In case of a GIT, it will be, it will stimulate the vagus nerve to release more acids, right? Because ultimately vagus nerve release the acetylcholine to stimulate the muscarinic receptor so that the acid could be released, right? So if you give a patient who is a COPD or asthma, okay, so it can lead to the exacerbation of COPD and asthma in case of these patients because of the bronchoconstriction. Okay, so, and that's why non-selective type of these receptors, the non-selective cholinomimetic agents, they are always contraindicated in case of COPD or asthma because they will cause the bronchoconstriction. Similarly, if a patient already have a peptic ulcer disease, you always want to avoid these agents because it will cause an increased release of gastric acid, right? So be careful with these patients while giving these drugs. Okay. Then the direct agonist agents, which directly stimulate the acetylcholine receptors, okay, the muscarinic receptors mostly, and one of them is the bethanicol. You guys already know this drug from the micturition reflex. Remember, the bethanicol, it will cause the, what does it cause?
Urinary incontinence.
Why?
Because
What
it
muscle?
contracts the retrosum muscle and relaxes the sphincter.
It won't. Yeah, that's a confusion. Please see, only the alpha receptors are present in the, in the sphincter. Okay, only the alpha receptors are there in the sphincter, so it won't relaxes the sphincter. It just causes a constriction of the detrusor muscles. Okay, understand this fact. Only the alpha receptors are present in the sphincter, so it won't causes the relaxation or the constriction of the sphincter. It just causes the constriction of the detrusor muscles. Okay, so that's why the urination will occur. So where you will use these drugs? In the urinary retention. Okay, most importantly in the post-operative urinary retention. So they will cause the incontinence, something like that. Okay. And these drugs, they do not have any nicotinic activity. They just have the muscarinic activity. Okay, very important. And what receptors are found in the bladder? The muscarinic receptors.
Beta
M1, M2 or M3?
M3.
The muscarinic ones I'm asking.
M3.
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 Okay. Yeah, exactly. And they are not found in the sphincter. They are found only in the muscles, the detrusor muscles. Okay, please do not get confused in these things, right? Then comes the carbachol, which is kind of a carbon copy of acetylcholine. Okay, but they're kind of resistant to the acetylcholine esterase. Okay, and where do we use these drugs? In the open angle glaucoma, because I told you that in case of a glaucoma, they will increase the drainage of the aqueous humor through the canal of Schlemm, right? So you can use these drugs for the treatment of open angle glaucoma to relieve the intraocular pressure. Okay, and they will constrict the pupil, you will get the meiosis. Okay, then comes the methacholine, and methacholine, you guys remember from the respiratory section, the methacholine challenge. Okay, because it causes the bronchoconstriction, and like I told you, it will cause the exacerbations of COPD. And because this drug has a very short duration of action for like seconds, so once you give these patients these drug, what can happen? It will cause a bronchoconstriction. It will cause the exacerbations of COPD for a second, and that's how you know that the patient is having a asthma. And you will specifically use this drug only in those patients which have a normal respiratory function test. Okay, only in these patients which have a normal respiratory function test, you will give those patients the methacholine challenge to diagnose them for the asthma. If the bronchoconstriction does not occur, if the exacerbation of the disease does not occur, that means the patient is not having asthma, right? So very important to know about this methacholine. Then comes the pilocarpine. Pilocarpine is mostly used for the open angle as well as and this close angle glaucoma. And one of the most important area in which you use this drug is the Sjogren syndrome. Okay, because you guys know in the Sjogren syndrome, you will get a very dry eyes, dry mouth, right? But once you stimulate the muscarinic receptors are found in the sweat glands and in the salivary glands, remember? So you use this drug for the Sjogren syndrome treatment. Okay, and and you guys remember the cystic fibrosis sweat test, where you induce the sweating and you will check for the electrolyte imbalance in the sweat. If you get a high or low concentration of chlorine in the sweat,
Hi.
high concentration, that means it is a case of cystic fibrosis. Yes. So for the diagnosis of cystic fibrosis, for the Sjogren syndrome, for the glaucoma, okay, to stimulate the sweating, tears, and saliva, you will use the pilocarpine. Okay. And this pilocarpine can easily cross the blood-brain barrier. Okay. It is important to remember. Pilocarpine can cross the blood-brain barrier, so you can also get the side effects like the neuro side effects. Okay. Then comes the indirect acting agonist, which are the drugs. They inhibit the acetylcholine esterase, and acetylcholine esterase is an enzyme which degrades the acetylcholine in the synaptic cleft. Okay, so it will decrease the concentration of acetylcholine in the synaptic cleft. So you use these drugs to inhibit the acetylcholine esterase, and as a result, the concentration of acetylcholine in the synaptic cleft could be increased, and you will get the symptoms or the effects, right? So first drug are the donepezil, rivastigmine, and the galantamine. Very important to know. Step one, they do not give you donepezil or rivastigmine. They will give you instead the galantamine. So you need to remember all of these three drugs: the donepezil, rivastigmine, and the galantamine. Okay, they are used for the treatment of Alzheimer's disease because they stimulate the muscarinic receptors there. They will cause the increased release of acetylcholine there. And one of the cause of the Alzheimer's disease is the loss of acetylcholine. Okay, so you give these drug to the Alzheimer's patient. Then comes the adrophonium. Okay, adrophonium is used to diagnose the myasthenia gravis. Okay, and how does you use this drug to diagnose the myasthenia gravis? See, if you're already giving a patient too much a cholinomimetic agent, then what gonna happen? With the receptors on the muscle, they will be desensitized, and what you will get is a symptoms just like the myasthenia gravis, right? Once you give the patient too much of these agents, with the receptors on the muscle, they will become the desensitized, and what you will get is the symptoms like the myasthenia gravis. And if the patient is actually having a deficiency of these agents of the acetylcholine or the receptors, then you will also get a myasthenia gravis. So once you give the adrophonium to the patient, and let us suppose a patient has a myasthenia gravis, then the patient will get the improvement in the symptoms, right? And if the patient is having the toxicity of these agents, and if you give the patient adrophonium, then no symptom improvement will occur, right? And that's how you know the patient is having a myasthenia gravis. Okay, you understand this test? Or should I repeat myself again?
No.
Okay.
Understood.
Yeah. Then comes the neostigmine. Neostigmine has two actions. First, it can increase the acetylcholine concentration, and second thing, it can directly stimulate the receptors of the acetylcholine. Okay, it can directly stimulate the acetylcholine receptors, first thing, and second thing, it can also increase the concentration of acetylcholine in the synaptic cleft. So you use these drugs for the myasthenia gravis. You can use these drugs for the urinary retention treatment, post-operative. Okay, and you can also use these drugs for the post-operative constipation. Okay.
Can you repeat that? Neostigmine?
Okay, neostigmine has two actions. First, it will inhibit the acetylcholine esterase to increase the concentration of acetylcholine. Second thing, it can directly stimulate the ACS receptors. Okay, two things. It increase the concentration, and secondly, it will directly stimulate the receptors. So you use these agents for the urinary retention treatment. You use these agents for the myasthenia gravis, and you can also use them for the constipation, post-operative constipation, or the paralytic ileus. Okay.
Okay.
Remember the function of neostigmine. Then comes the physostigmine, and it is a drug which can easily cross the blood-brain barrier. Okay, so you always use this agent whenever you get a toxicity from the cholineolytic agent or the sympatholytic agent, like the atropine. Okay, you will always use this drug for the toxicity of the atropine or the anticholinergic toxicity. Why? Because it will inhibit the symptoms both inside the brain as well as outside the brain in the body, because it can easily cross the blood-brain barrier. So it will always reverse every muscarinic symptoms in the body. So physostigmine for the treatment of anticholinergic toxicity. Then comes a pyridostigmine, which is a kind of long-acting drug. Okay, long acting than the neostigmine, and that's why you can use this drug for the myasthenia gravis. Okay, and you always use these agents with some anti-muscarinic agents also. Why? Because in case of a myasthenia gravis, you just need the nicotinic symptoms. Okay, you just need to stimulate the nicotinic receptors, not the muscarinic receptors. So you always give these agents with some anticholinergic agents like the glycopyrrolate or the hyoscyalamine, which inhibits the muscarinic receptor so that you won't get any muscarinic symptom. Okay, please remember this fact: the glycopyrrolate or the hyoscyalamine or this propanthyline. Okay, to control the muscarinic symptoms, because you just need the nicotinic receptors stimulation in case of myasthenia gravis. Okay, so any doubt so far on these agents, the cholinomimetic agents? Any doubt?
No, thank you.
Okay, then comes the anticholinesterase poisoning. Okay, all of these agents are the anticholinesterases, right? And if you give these agents in too much amount, so what you will get is the muscarinic symptoms as well as the nicotinic symptoms. For the muscarinic symptoms, what you will get in the eye, you will get the miosis, you will get the high intraocular pressure. Okay, in the mouth, you will get the salivation. In the sweat, you will get the sweating, right? In the heart, you will get the slowing of the heart rate. Okay, you will get the low BP, right? And what you will get in the lungs, you will get the bronchoconstriction. So you will get the respiratory distress. In case of a GIT, you will get the diarrhea. In case of a urinary tract, you will get the urination, right? So the diarrhea, urination, meiosis, bronchospasm, sweating, lacrimation, emesis, okay, which is the vomiting, salivation, and the bradycardia. These are the side effects, the muscarinic side effects of the anticholinesterase poisoning. Okay. And all of these symptoms can be easily reversed by the atropine, because atropine is an anti-muscarinic agent that can easily cross the blood-brain barrier. So it will inhibit the symptoms of this muscarinic muscarinic receptors both in the brain as well as outside the brain. And that's why the first thing that you will give to the patient whom you suspect in the anticholinesterase poisoning is always the atropine. Okay. Then comes the nicotinic symptoms. After the stimulation of the nicotinic receptors, what you will get is the spasms. Okay, and ultimately desensitization will occur, and what you will get is the paralysis. So you will get the fasciculation, you will get the weakness, you will get the paralysis, you will get the spasms. Okay, and of course you will get the hypertonia, so hyperreflexia would be there. Okay, and once the muscle become paralysis, see in you know if one of the respiratory muscle become paralyzed, what can happen? The patient will get the respiratory distress and ultimately the patient will die, right? So you need to protect these nicotinic effects also. Okay, and to protect the nicotinic receptors, you will have to give the patient pralidoxin. We will study that later again. Just wait for a second. So you will get the paralysis. If the paralysis of the respiratory muscles occur, the patient can even die. Okay, and the CNS symptoms, you will get the respiratory depression. Okay, you will get the lethargy, you will get the seizures, and you will get the coma. Okay, so the important drugs that you must remember for the acetylcholinesterase poisoning are the parathion or the malathion. Okay, and where did you study these drugs? Remember where these drugs are used? We have studied them already in the previous lectures. Anyone remember?
Insecticides or pesticides?
Insecticides, pesticides are good. Okay. But in the previous lecture in the microbiology, remember the use of these agents?
Bioterrorism.
Yes.
Not the bioterrorism.
In the scabies.
Scabies, yeah, scabies and these the Perthes pubis and the Pediculus humanus capitis. Remember, we use these the parathion and the malathion to treat the conditions. Okay, don't forget it. Okay, so the parathion and malathion, they are the irreversible inhibitor of the acetylcholinesterase. Okay, so they inhibit the acetylcholinesterase irreversibly. Okay, and generally you use these drugs in the farming for the insecticides and the pesticides, and generally the poisoning will occur in the farmer. So it will always gonna be a case of a farmer, okay, or sometimes a child who try to who try to commit a suicide. Okay, so farmer or a societal case it could be. Okay, and how you will treat the conditions? The first step is to give the patient atropine, because atropine will reverse all the muscarinic symptoms in the brain as well as outside the brain. Then after giving the patient atropine, you have to give the patient palidoxime. Otherwise, the patient will get the paralysis of the muscles, of the respiratory muscles or other areas, right? So he can die of it. Okay, so palidoxime, which will regenerate the acetylcholine via dephosphorylation. And you need to know that you have to give this drug as soon as possible after the atropine. Okay, because once the aging, which is a phenomena of it, I don't exactly remember this phenomena, but this aging is occur in the acetylcholinesterase, and once the aging is occur, then this drug will no longer be effective. Okay, so you have to give this drug before the aging of the acetylcholinesterase occur. Okay, and yeah, this drug they do not cross the blood-brain barrier, so they will only protect the nicotinic symptoms outside the brain. Very important to know. So treatment includes the first the atropine, and after the atropine is given, you will give the patient pyridoxine to reverse the nicotinic effects. Okay. Any doubt on this poisoning?
Why are we giving glycopyrrolate with pyridoxine in myasthenia?
Okay, so see, in case of a myasthenia gravis, what symptoms you want to treat? Tell me.
That
The paralysis
muscles.
part, right?
Yes.
Yeah. With the weakness, the paralysis you want to treat, right? And what receptors you want to stimulate in this case? Nicotinic,
Muscarinic.
right?
Yeah, Nico.
No, not the muscarinic. The NM receptors are found in the muscles, right? So you want to stimulate
Yes.
the nicotinic receptors, not the muscarinic receptors. If you give the patient pyridoxine, both the muscarinic as well as the nicotinic receptors will be stimulated, because it is just increasing the acetylcholine, right? It has no any targeted activity. Okay, it has a diffuse activity both on the nicotinic as well as the muscarinic receptors, but you just want the stimulation of nicotinic receptors in this case. So you want to inhibit the muscarinic side effects, and to inhibit the muscarinic side effects, you need to give the patient anti-muscarinic agents like glycopyrrolate and the hyoscyamine, right? That's why, because you do not want the muscarinic symptoms, you just want the nicotinic effects.
Okay.
Okay. Okay, so any other doubt? No? Okay. Then comes the anti-muscarinic agents. Okay. And for the anti-muscarinic agents, those who act on the CNS. Okay, first we start with the CNS and we go for the eye, then for the lung, then for the heart, and then for the urinary tract. Okay, in the sequential order. Okay, so so first is the CNS. Drugs that act on the CNS as a benstropin and trihex. Okay, trihex and benstropin, you will use this drug for the Parkinson's treatment. Okay, because in case of a Parkinson, what neurotransmitters is gonna lose, and what neurotransmitter will become too much.
Dopamine is lost and acetylcholine is increased.
Exactly. So you want to inhibit the acetylcholine. So you will give the patient benstropin or the trihex. Okay. So for the treatment of Parkinson's. Second, for the treatment of acute dystonia, because it is the acetylcholine which is causing the stimulation of nicotinic receptors to cause the spasms, right? And that can lead to dystonia, right? A contraction of a muscle group is known as a dystonia. Okay, so you want to treat the condition by giving the patient benstropin and the trihex. Okay, for the motion sickness, because the muscarinic M1 receptors are responsible for the motion sickness, you will inhibit those receptors by giving the patient scopolamine. Okay, so scopolamine for the antiemetic agent for the motion sickness. Okay, then the eye, and in the eye you will use you will use this drug, the tropicamide. Okay, you will use the homatropin and you will use the atropine. Okay, you will use, in case of adult you will use the homatropin, in case of child you will use the atropine. Okay, and again the tropicamide. What this drug gonna do, they will inhibit the muscarinic receptors, so you will get the cycloplegia. Okay, and it is a light non-responsive type mydriasis. Why? Because you are inhibiting the muscarinic agents, so with the muscarinic receptors. So, and as a result, only thing you will get is the mydriasis. No meiosis can happen, right? So it is a light, non-responsive type mydriasis. Okay, and the cycloplegia. Then, in case of a respiratory area, you will give the patient hyoscyamine or the dicyclomine to inhibit the muscarinic receptors. Oh, sorry. In case of respiratory, you will use the ipratropium and the tiotropium bromide. Okay, and you will use this drug for the treatment of asthma and the COPD. Mainly for the COPD and secondarily for the asthma, you will use this drug, the ipratropium and tiotropium bromide. Okay, you will use the glycopyrrolate to clear the secretions from the respiratory tract. Okay, and you will use these drugs as a preoperative agents. Okay, to reduce the airway secretions. Very much important. Glycopyrrolate, right? Then for the GI tract, you can use the hyoscyamine and the dicyclomine for the treatment of irritable bowel syndrome. Okay, because they work as the antispasmodic. They will release the spasms and they will release the pain in the with the spasmodic pain in the patient, right? So they are the antispasmodic agents. Okay, used for the irritable bowel syndrome. Very important, hyoscyamine and the dicyclomine. Similarly, you can use the glycopyrrolate in the GI tract also to clear the GI secretions. Okay, and just like that, you will use this drug in the preoperative conditions just before the surgery, because you want to clear the secretions for the endoscopy or for any tube passage, right? So you use the glycopyrrolate for it. Okay, then the oxybutynin and the toltetrasidine, okay, and the solifenacin. Okay, oxybutynin, solifenacin, and the tolteridine. Okay, for the urinary tract area, and it will does what? It will reduce the bladder spasms. Okay, so you will use in the treatment of incontinence or in the case of overactive bladder. Okay, very much important to know. Okay, so we have covered these drug. Any doubt?
No.
No.
Okay. Okay, then comes the atropine. Okay, and where does you use the atropine? In case of eye and in case of a heart. Whenever you got a patient who is having a bradycardia, because you guys know that this atropine will inhibit the muscarinic receptor, so you can never get the bradycardia, right? So whenever you encounter a case of a patient having a very low heart rate, you will always use the atropine in those patients. Okay, so atropine is a muscarinic antagonist and most commonly used in the treatment of bradycardia. Okay, but what gonna happen if the toxicity of this atropine happen, right? Or what the side effects of the atropine? Like in case of a eye, you will get the pupillary dilation, you will get the cycloplegia. Okay, in case of airways, you will get the bronchodilation, and you will get a decreased secretions. Okay, in case of a stomach, you will get a decreased acid secretion. Okay, in case of a GIT, you will get the constipation. In case of a bladder, you will get the increased retention of urine in the bladder. Okay, in case of a sweating, because the muscarinic receptors are present in the sweat glands, you will get the dryness. Okay, you will get an increase in the body temperature because of loss of sweating, and once the sweating is lost and the body temperature is increased, thus the parasympathetic system will be activated in the body, and it will dilate the blood vessels in the peripheral regions, right? And and once the peripheral blood vessels will rise, what gonna happen? The blood will be increased in the with the blood supply will be increased in the peripheral tissues, right? And what you will get is the redness completely in the body, and that's why in case of a loss of sweating, you will get the dry and the flushed skin. That is the cause because of the vasodilation. Okay, and yeah, in case of a eye, you can also get the acute angle closure glaucoma. Very important. Okay, so it would be a patient who is having a history of bradycardia, a old age patient. And for the treatment of bradycardia, you have given the patient atropine, and soon after the atropine, the patient got the severe eye pain. So they can ask you why the severe eye pain is occurring, and it is because of the acute angle closure glaucoma. Okay, and sometimes they can also give you, the history of the patient with the bradycardia, and after some time, you will give the patient certain drug. They won't give you the name of the drug. Okay, and after giving the drug, the patient got a severe eye pain, so they can ask you what could be the name of the drug. So it would be the atropine or the anti-muscarinic agents. Okay, so what are side effects of the atropine? They will increase the body temperature because of loss of sweating. You will get an increased heart rate. Okay, you will get a dry mouth because of loss of salivation. You will get the dry skin because of loss of sweating, and because of the loss of sweating and high body temperature, the vasodilation will occur, right? And because of the vasodilation, you will get the flushed skin. You will get the cycloplegia. You will get a disorientation because this atropine can easily cross a blood-brain barrier. So you will get the anti-muscarinic symptoms in the brain also. One of them is the disorientation. In the GI tract, you will get the constipation. Okay, you can also get the severe eye pain, which is a glaucoma. Okay, you will get the urinary retention. Okay, and it can worsen the symptoms in case of a patient with BPH. Okay, and hyperthermia, of course. So what would the treatment of atropine poisoning? We have discussed it. The
Physostigmine,
treatment of physostigmine. Why physostigmine?
because it
Why
can cross
physostigmine?
blood-brain barrier.
Exactly. And yeah, and if they do not give you a history of atropine, they can tell you of a patient who is a gardener or working in the garden. Okay, so remember about this, the Jimson weed, also known as a dhatura. Okay, it works similar to the atropine and can and the patient can get these symptoms. Okay, so it would be a history of a patient who is working on the on the garden, and suddenly the patient is starting having these symptoms. Okay, so you can easily detect that this must be a case of the Jimson weed or the dhatura. Remember these things. Okay, and the other drugs that has this acetylcholinergic activity, these are the TCAs, the antihistamine drugs. Okay, and the sleeping agent pills, like the benzodiazepine drugs. Okay, some of the benzodiazepines also has the anti-acetylcholine activity. Okay, so these drugs, they can also do the same thing. Okay, the TCA, the antihistamines, and the sleep aid pills, like the benzodiazepines. So all of these three things, they can also lead to the similar side effects. Okay, any doubt on this page?
No.
Okay. Then comes the sympathomimetic agents, okay, which mimic the sympathetic effects. All of these agents stimulate either the beta receptors or the alpha receptors or both, right? So first are those agents which stimulate the beta 1 receptors. And you guys remember the location of beta 1 receptors?
Heart,
and
lung,
Kidney.
lungs.
Kidney.
Kidney.
kidney,
Where in the
sir.
kidney?
JG cells.
Exactly. And what does they do?
Renin
Secretary.
secretion.
Renin secretion.
Exactly. Yeah, good. Okay. So the agent which have a predominant beta 1 effect are the dobutamine. Very much important. The dobutamine, it has a predominant beta 1 effect. So what is it gonna do? It will increase the heart rate. Okay. It will increase the blood pressure. Okay. And third thing, it will increase the renin. Okay. So mostly you use these drugs for the heart failure or the shock. Okay, because they are the positive inotropic agent. They will stimulate the heart rate. They will increase the contractility of the heart. I think they will increase the conduction pathway of the heart, if you guys remember, right? So for the cardiogenic shock and for the heart failure, you will use these agents. What's going to happen with the BP? Either the BP will remain normal or the BP can also sometimes drop because of the beta 2 stimulation. They have the milder beta 2 effects also. Okay, heart rate will increase and the cardiac output will also increase. Okay, and what's gonna happen if the patient is having a atherosclerosis in the heart? Okay, what's gonna happen to this patient? If you give the patient dobutamine, then the demand of the oxygen by the heart would be increased. But if the patient is already having a vasospasm or the atherosclerosis in the cardiac vessels, the oxygen demand can never be matched with the oxygen supply, and what the patient will get is the chest pain. Okay, so you can use the dobutamine as a cardiac stress testing also. Okay, because in case of an angina, there is a supply demand mismatch, right? The supply is low, but the demand is high. So what you're gonna do, you will increase the demand of the heart, but the supply would be decreased as a result. And what you will get is a chest pain. So it is used for the diagnosis of the angina in the cardiac stress testing. Very important. Okay.
Can you repeat that?
Okay. So see, in case of an angina, okay, you are having the atherosclerosis or the vasospasm of the cardiac blood vessels, right? Okay. So the supply is already very much low. Okay, the supply of oxygen is low, in the heart. So what's gonna happen once you increase the demand of the heart by increasing the cardiac output, by increasing the contractility, by increasing the heart rate, the heart will require more oxygen, more blood to function, right? But the supply is already very much low. Okay, so there would be a supply demand mismatch occur. Okay, supply is low, but the demand is high. So a supply demand mismatch will occur, and what you will get is a chest pain. Okay, because the symptoms of angina you will get, and that is how you will use this drug in the cardiac stress testing. So after giving the dobutamine, if the patient get a chest pain, that means the patient is having a angina, a stable angina, I must say. Okay.
Okay.
So now the agents which have a predominant beta 2 effect, these are the albuterol, salmeterol, and the terbutaline. Okay, albuterol, salmeterol, and the terbutaline. Okay, so what they will do, they will cause a little increase in the heart rate because they have a very minor beta effect. The beta 1 effect. They have a major beta 2 effect. Okay, so what they're going to do in the lung? They will cause a bronchodilation. So they are used for the treatment of acute asthma. Okay, they are used for the treatment of acute asthma. Okay, and mostly the albuterol could be used because it is a short-acting drug and it has a very rapid onset of action. Okay, so for the acute exacerbations of the asthma, you will always give the patient albuterol. Okay, salmeterol has a very longer duration of action, and it take time to cause the effects. Okay, so you cannot use the salmeterol for the acute asthma. You will use them for the asthma in the long term axis. For the prophylaxis of the asthma, you will use the salmeterol. Okay, then the terbutaline, it is used as a tocolytic agent. Okay, because the beta receptors are also found in the uterus and they will cause a relaxation in the uterus. Okay, so in case of a premature labor, you will give the patient terbutaline. Okay, as a tocolysis, right? Then comes those agents which have a equal beta 1 as well as a beta 2 effect, and these are the isopreterenol. Okay, isopreterenol, which has a equal beta 1 and beta 2 effect. Okay, So because they have a equal beta 1, beta 2 effect, they will cause the vasodilation, and as a result, the loss of blood pressure will occur. The drop in the blood pressure will occur. They will cause it the increase in the heart rate, and it is not a reflexive heart rate increase. It is a direct heart rate increase. One is a reflexive and one is a direct. In case of a vasodilation, because the BP is dropping, the sympathetic system will be activated and it will increase the heart rate. It is an indirect heart rate increase, right? But here in this scenario, because they're stimulating the beta 1 receptor directly, so you will get a direct heart rate increase. Okay, and you will get an increase in cardiac output. Okay, and just like any other beta 1 stimulating agent, they can worsen the ischemia because of the supply demand mismatch, right? And they have a negligible alpha effects, very much important. Okay, then comes those agents which have a effect on the dopamine receptors. Okay, and these are the dopamine itself. Okay, see, the effect of the dopamine is dependent upon the dose of the dopamine. Okay, at a low dose, the dopamine has a D action more than the beta or the alpha receptors. It will stimulate the dopamine receptors more than the beta or alpha receptors. At a moderate dose, the dopamine has a beta receptors stimulation more than the dopamine or the alpha receptors. And at a very high dose, the dopamine has a predominant alpha effect than the beta or this D effect. Okay, so at a low dose, it will stimulate the dopamine receptors more than the beta alpha receptors. At a moderate dose, it will stimulate the beta receptors more, and at a very high dose, it will stimulate the alpha receptors more. Okay, and that's why at a very high doses, you will get the high blood pressure, you will get the high heart rate, as well as the increase in the cardiac output because of the beta stimulation also. Okay, so you will always give this agent in a low dose to increase the renal blood flow. Whenever the renal ischemia is occurring, you will give the dopamine at a very low dose to increase the renal blood flow, because these are the only agents which increase the renal blood flow. Okay, you can use these agents for the unstable type of bradycardia in case of a heart failure, in case of a cardiogenic shock. Okay, because they have a positive inotropic as well as a this chronotropic effect. Okay, and they will get the vasoconstriction at a very high dose due to the alpha effect. Very much important to know. Okay, then the agent which has just the dopamine effect is the phenol-dopam. It can only stimulate the D1 receptors. Can anyone tell me what kind of G protein couple receptors are the D1 receptors?
GS protein.
What exactly?
Stimulatory.
Exactly. So they will cause the increase in the vasodilation, and you will get the loss of blood pressure. And because of the loss of blood pressure, the sympathetic system will be activated and you will get a reflex tachycardia and reflex increase in the cardiac output. Okay. So you can use this agent as a post-operative hypertension. Ultimately, you will get the low BP, but you will get the high heart rate and high cardiac output. So you use this agent for the post-operative hypertension, vasodilation, especially for the renal areas, for the coronary, and for the peripheral also. Okay. And because they increase the renal blood flow, the more blood filtering could be occur, and as a result, they will promote the natriuresis. Okay. And they can cause the hypotension and the tachycardia. Okay. Then comes the agent which has mostly beta effect than the alpha effect, the predominant beta effect, and these are the epinephrine. Okay. And epinephrine is used for the anaphylaxis. Why not the non-epinephrine for the anaphylaxis? Anyone?
Because it do not have this beta 2 effect.
Beta
So
2
it
effect.
cannot act
Exactly.
on bronchial smoke.
Exactly. And you need the bronchodilation in case of anaphylaxis, because histamine causes a bronchoconstriction. So we'll get the respiratory distress. And in order to reverse the respiratory distress, you need to give an agent which can stimulate the beta 2 receptors. And these are the epinephrine. Okay. You can use these drugs for the asthma, for the open angle glaucoma treatment. Okay. And if you give this agent in a very high dose, okay, then alpha effect would be predominates. So you always give this agent in a low dose. Okay, very much important to know. At a higher dose, you can get the increase in the blood pressure, and by direct stimulation of the beta 1 receptors, you can get the high heart rate, and the high cardiac output. Okay. So that's all about all these agents which have a predominant beta effect. One more agent, which is the mirabegron, which stimulates the beta-3 receptors, and these are the receptors which are found on your urinary bladder. It will cause the relaxation of the detrusor muscles there. So you will get the urinary retention. So you use these agents in the incontinence. Okay, very much important to know. Then those agents which have a predominant alpha effect, then the beta effect. Okay, and these are the non-epinephrine. Okay, it has a mostly alpha effect, then the alpha 2, and finally the beta 1 effect only. Okay, so what you will get is a vasoconstriction, that means a high BP, and because they have a predominant alpha effect, not the beta, so because of this high blood pressure and vasoconstriction, you will get the reflex bradycardia or a loss of heart rate. Okay, the cardiac output can be slightly increased or can remain same because of the bradycardia, and as well as you are stimulating the beta 1 receptors, but you are also having the bradycardia. So you will get a slightly increase in the cardiac output, or the cardiac output can be normal. Where you would use these agents for the hypotension and for the septic shock. Okay, so for the septic shock, you will use the non-epinephrine. For the anaphylaxis, you will use the epinephrine. Then comes the phenylephrine, which has only the alpha effect, no beta effect. So you will get the unopposed vasoconstriction by the alpha 1 effect. Okay, you will get the reflex bradycardia, and you will also get the loss of cardiac output, both because of the of this loss of heart rate, and second because of the vasoconstriction, because you know the SVR is increased now. Okay, the vascular resistance is increased, so you will get the loss of cardiac output. Okay, where you would use this agent for the treatment of hypotension because they're a vasoconstrictor. You can use them as a mydriatic agent in the ocular procedures. Okay, you will use these agents for the rhinitis because they are decongestant. They will cause the vasoconstriction in the nose so that the obstruction could be easily relieved. Okay, so you will use them as the decongestant. But you guys remember the tachyphylactic thing. If you use these drugs continuously for 3 to 5 days, then ultimately what's going to happen? The tachyphylaxis will happen and their effect would be decreased. The patient will have to increase the dose of this agent to get a similar effect. But ultimately what's going to happen is the rebound rhinorrhea. Okay, rebound rhinorrhea. And the treatment of the rebound rhinorrhea is to stop the agent as soon as possible, right? And you can also get the ischemic priapism because they increase, because it causes the the vasoconstriction there. So you will get the because of the venoconstriction, you will get the ischemic priapism also. Okay, then comes a drug which is a metodrin. It has just the alpha 1 effect. Okay, it can lead to the increase in blood pressure, loss of heart rate, and loss of cardiac output. Okay, you use this agent mainly for the autonomic insufficiency or for the postural hypotension. Okay, most important thing for the postural hypotension. Okay, I think we have covered every drug here now. Okay, so first we have studied all the drugs which have a beta 1 effect predominantly. Then we have studied with those drugs which have an equal beta 1 as well as a beta 2 effect. Then those drugs which have a predominant beta 2 effect. Then those drugs which have a D effect, the dopamine effect. Then those drugs which have a most beta effect, then the alpha effect. Okay, and finally those drugs which have the alpha effect more than the beta effect. In that sequence, if you try to remember those drugs, then it would be very easy to remember them, right? Very important. Any doubt?
Norepinephrine is the decreased heart rate.
Yeah.
The
Reflex decrease in the heart rate. Reflex decrease in the heart rate because of parasympathetic activation, right? That's why.
Okay.
Then because alpha effect is more than the beta, although they're stimulating the beta receptors, but the alpha effects are more than the beta effects, right? And bronchoconstriction always, in this case, because alpha effect is more, the bronchoconstriction will overtake the beta effect of the heart rate, right? So you will get a more reflex bradycardia than the tachycardia. Okay? That's why the loss of heart rate. It is all relative.
Okay, thank you.
Okay, then comes the indirect sympathomimetic agents. And these are the agents which increase the non-epinephrine concentration in the synaptic cleft. Okay, we have studied this drug already, the amphetamine. Remember the function of this amphetamine? They will use the NET receptors, then they will use the VMAT receptors to replace the non-epinephrine in the vesicles, so that the concentration of non-epinephrine would be increased in the axons, and as a result, the release of non-epinephrine will be increased and uptake of the non-epinephrine would be decreased. Okay, so they are used for the treatment of narcolepsy, okay, for the obesity, and for the ADHD. You will study all these diseases later in the psychiatry. Okay, narcolepsy, obesity, and the ADHD. Then comes the cocaine. Okay, cocaine can cause a vasoconstriction. Okay, generally cocaine can also used as a local anesthetic because it also inhibits the sodium channels. Okay, so it can also be used as the local anesthetic. It can cause the bronchoconstriction, and that's why you can have a nasal perforation in case of a cocaine use. You can have a myocardial infarction in case of a cocaine use, and the patient can die with the myocardial infarction after the cocaine. Okay, and you do not need to give the patient beta blockers. If you give the patient beta blockers, then you will get the unopposed alpha-1 activation, and as a result, you will get the vasospasm, myocardial infarction, and even the death of the patient. Okay. Then diphenhydramine, which basically increases the release of non-epinephrine. Okay, they can be used as a nasal decongestants. Okay, they can be used as the urinary used in the treatment of urinary incontinence because they will stimulate the alpha receptors to cause the constriction of the sphincter. They will stimulate the beta receptors to cause the deuterational muscle relaxation. So they can be used for the treatment of urinary incontinence. They will be used for the treatment of hypotension because they will stimulate all the beta alpha receptors to cause the hypertension. Okay, so that's about diphenhydramine. Then comes the non-epinephrine versus the isoproterenol. Okay, what is the function of this isoproterenol? What receptors it will stimulate?
Beta,
Beta 1 and beta 2.
beta 1, beta
Or be
2.
equally, right?
Yeah.
And this non-epinephrine, it will stimulate the alpha 1, alpha 2, and the beta 1.
Beta 1.
Okay. Okay, now see. In case of a non-epinephrine, what's going to happen to the blood pressure? Because of the vasoconstriction and alpha effect is more, the vasoconstriction will be predominated, right? So what you will get is the increase in the blood pressure, right? This is a diastolic blood pressure. Because of the vasoconstriction, it would be increased. Okay, you will also get an increase in the systolic blood pressure, and ultimately the mean blood pressure would be increased. Okay, what's going to happen with the heart rate? Because of the reflex bradycardia, because alpha effects are predominated than the beta effects. So what you will get is the reflex bradycardia. Okay, what is the peripheral resistance? Because they have just the alpha effect, not the beta 2 effect. So vasodilation can never be happen, right? What you will get is the unopposed alpha 1 effect. So ultimately the cardiac output, because of this reflex bradycardia and the beta stimulation, you will get the cardiac output which could be normal or could be decreased. But you will get the reflex bradycardia, you will get a very high mean arterial pressure, and you will get the increased in the pulse pressure. Okay, the first thing. In case of a isoproterenol, because they have a both, they have a mostly beta effect and equal beta 1, beta 2 effect. So what you will get is a vasodilation by the beta 2. And so you will get a very low diastolic blood pressure. Okay, because you get an increase in the heart rate and increase in the cardiac output, what you will get is the increased systolic blood pressure. Because of an increase in the cardiac output, you will get the increase in the systolic blood pressure. So ultimately the mean blood pressure either could remain same or slightly decreased. Okay, but because of the beta 1 stimulation and as well as a reflex tachycardia, what you will get is a very increase in the heart rate. You can see that. And because the isoproterenol, they do not have the alpha 1 effect. Okay, so you will get the unopposed beta 2 effect. You will get the very low peripheral resistance. Okay, so cardiac output is very much increased, both because of reflex tachycardia and as well as the beta 1 effect. The heart rate could be increased in the same way. The mean arterial pressure is decreased and the pulse pressure becomes so much widened. As you can see, the pulse pressure is a difference between the systolic blood pressure and the diastolic blood pressure. See, the difference is too much. In case of epinephrine, epinephrine has both the alpha 1, alpha 2, beta 1 as well as a beta 2 effect, right? So in case of blood pressure, what gonna happen? The beta 2 effects would be predominated. Okay, the beta 2 effects would be predominated, and what you will get is a slight vasodilation because the alpha effects are also there. So you will get a slight vasodilation. Okay, because of the stimulation of beta 1 receptors, you will get an increase in the heart rate and increase in the cardiac output. So you will get an increase in the systolic blood pressure. Okay, increase in the systolic blood pressure would be there. So ultimately, you will get a slightly increase in the mean arterial pressure, a slight increase in the mean arterial pressure. Because of the beta 1, you will get an increase in the heart rate. And what about the peripheral resistance? Because alpha 1 effects are also there. Okay, not just a beta 2 effect. So you will get a slight vasodilation, and that's why a slight decrease in the peripheral resistance, not like the isoproterenol, which has just the unopposed beta 2 effect. Because you have the alpha effects also, so you will get a slight vasodilation, and that's why the slight drop in the peripheral artery resistance. So the cardiac output will be increased, the heart rate would be increased because of a direct stimulation of beta 1 receptors. The mean arterial pressure would be increased, as well as the pulse pressure would be increased. Okay, so that's about the difference between a non-epinephrine, epinephrine, and the isoproterenol. In case of a non-epinephrine, there is no beta 2 effect, so unopposed vasoconstriction and the bradycardia. In case of epinephrine, you have the beta 2 effect as well as alpha effect. So a relative thing would be there, a slight vasodilation, increase in the heart rate, and a slight increase in the mean arterial pressure. In case of isoproterenol, you will get a beta 2 effects mostly, right? So you get the vasodilation and the tachycardia, right? I think we should take a short break here of 5 to 10 minutes, then we will be back again, okay?
Sorry to disturb you, but just one thing.
Yeah.
Just,
Please ask.
discuss what parameters affect the systolic and diastolic blood pressures.
See, systolic is
cardiac.
Yeah, the cardiac output, the heart rate, as well as the vasoconstriction. All these three things affect the systolic blood pressure. Okay, and for the diastolic, it is mainly the vasoconstriction only. If you have the vasoconstriction, then you have an increase in the diastolic blood pressure. If you have a vasodilation, then you will have a drop in the diastolic blood pressure. Okay, but the vasoconstriction, the cardiac output, and the heart rate, all these three things control the systolic blood pressure. Okay.
Okay. So it's basically the cardiac output, heart rate, and the TPR that affects the systolic blood pressure, and it's only the
exactly
TPR that affects the diastolic blood pressure. Okay.
Only the TPR which affects the diastolic blood pressure. Yes. Okay. So any other doubt on this page?
The epinephrine causing an increase in blood pressure. Why is that? Can you explain once?
Epinephrine causing the increase in the blood pressure, the systolic blood pressure, not the diastolic one, because you have the beta 2 effects more than the alpha effects, you will get the loss of the diastolic blood pressure. But because it also has the beta 1 effect, so the cardiac output is increased, the blood flow is increased, right? The heart rate is also increased, and these effects are predominated, and that's why you are getting the increase in the systolic blood pressure. Okay, the systolic blood pressure is increased, diastolic blood pressure is dropped, so ultimately you will get a very heightened or a very wide pulse pressure. Okay.
Okay.
But it is not, but this systolic blood pressure is not as much high as in the non-epinephrine. Why? Because it is just because of the beta 1 receptors. The increase in the heart rate and increase in the cardiac output, because you're getting the vasodilation. So this systolic blood pressure would not rise as much as in case of a non-epinephrine. Okay, because you're having the vasodilation along with the high heart rate and high cardiac output. Okay.
Okay.
Yes, thank you.
So any other doubt? Okay, I think we should take a short break here, right?
Yes.
Okay, so we have discussed the difference between the non-epinephrine, epinephrine, and the isoproterenol. Please remember this diagram and the effects mainly, what they're gonna do, right? And now we are going to discuss the sympatholytics. And all the sympatholytics, they are the alpha-2 agonists. Like I told you, the alpha-2, these receptors are found in the presynaptic neurons. And the presynaptic neurons, they will decrease the release of non-epinephrine, right? by giving them the negative feedback. Okay, so the drugs include a just a second, guys. Okay, so the drug includes a guanfacine and a clonidine. Okay, and you use these drugs for the hypertensive urgency. In the limited situations only, you will use these drugs in the ADST, the Tourette syndrome, and the opioid withdrawal. Okay, very important. Opioid withdrawal, the Tourette syndrome, ADST, and the hypertensive urgency. Okay, what are the side effects of these agents? You will get a serious depression because you will decrease the norepinephrine and epinephrine in the brain. Okay, because of a loss of beta stimulation in the heart, you will get a bradycardia. Because of the vasodilation, because alpha receptors are now gone, you will get a hypotension, and of course because of the bradycardia also, you will get the respiratory depression. You will get the meiosis because of the muscarinic stimulations now, because the alpha stimulations in the eye is lost. Okay, you will get the rebound hypertension if you stop these drugs abruptly. Very much important. You will get the rebound hypertension if you stop this drug abruptly. So it would be a case of a patient whose whose medicines are now expired. Okay, and he forgot to renew the medications. So he will get the rebound hypertension. Okay, step 1 will ask you why the hypertension is now occurring in this patient. Why? Because of this abrupt stoppage of the drug. Okay, then comes the alpha methyl dopa. Okay, it is the same drug which which undergoes a acetylation, and it can cause the drug induced lupus. Okay, you use these drugs mainly in the pregnancy for the treatment of hypertension. It is very safe in the pregnancy. That's why it is used in the hypertension in pregnancy. Okay, it can cause the drug induced lupus and the hyperprolactinemia. Okay, then comes the tizanidine. Okay, which is a drug mainly used for the spasticity. You will study the effects later in the neurology section also. Whenever you get an upper motor neuron damage or the spasticity, you will use this drug, that is tizanidine, to relieve the spasticity. It can cause the hypotension, weakness, and the xerostomia, which is a dryness. Okay. It is just the effects and the applications that you must remember. You need to memorize everything: the hypertensive urgency, ADST, Tourette's, opioids, and the relief of spasticity. You need to remember all of these applications. Okay, any doubt on this page?
This alpha methyl dopa is also metabolized by acetylation.
Does what?
Alpha methyl dopa also by acetylation.
Yeah, exactly. Alpha methyl dopa also by the acetylation. Then comes the yeah, please ask.
For when we were in the guanfacine clonidine,
Yeah.
rebound hypertension, is that due to like decreased receptors? Why do we have that?
Yeah, exactly. This thing gonna happen, because what gonna happen, they will stimulate the alpha 2 receptors too much, that ultimately what gonna happen, the beta receptors and the alpha receptors, because there is no norepinephrine present, right? So the quantity or the concentration of these receptors would be increased in the body, because the body will try to do everything to get the same effect. Okay, so what the body gonna do, it will increase the density of the alpha receptors and the beta receptors, and as soon as you will stop these agents, the alpha 2 are gone, and now this non-epinephrine could be released from the nerve endings, and because the receptors are now too much, so this the non-epinephrine will stimulate these receptors, and what's gonna happen is the hypertension because of a high density of these receptors, the alpha receptors and the beta receptors. Okay, that's why.
Thank you.
So you always need to slowly would taper the dose of these agents so that you won't get the rebound hypertension. Okay, that's because increase the density of the alpha and the beta receptors. Okay, so now the alpha blockers. And for the alpha blockers, you have two types of alpha blockers. One is the non-selective, and second is the alpha 1 selective and the alpha 2 selective. Okay, for the non-selective type, you have the irreversible blocker and the reversible blocker. Okay, the irreversible one is a phenoxybenzamine. Okay, and you use the phenoxybenzamine for the treatment of pheochromocytoma. Okay, and it is used always pre-operatively. Okay, for the treatment of pheochromocytoma, when the surgery is going to happen, you have to give this drug before the surgery. Why? Because during the surgery, there will be an increased release of the catecholamines. And when the catecholamines are released, and they will stimulate the alpha and the beta receptors, right? So you will get the high sympathetic response. So to prevent this condition, you need to give the patient phenoxybenzamine so that the alpha receptors are inhibited. And you always need to give the alpha blockers first before the beta blockers. Very much important. You need to give the alpha blockers first before the beta blockers. Otherwise, you will get the unopposed alpha, the unopposed alpha stimulations, right? So before the beta, you will get the alpha, which is the phenoxybenzamine. And what's going to happen with the graph? The efficacy would be dropped, but the potency will remain the same. The Km value will remain the same, but the efficacy of the drug would be dropped. So you will get with this kind of a graph. Okay. Then comes the phentolamine, which is a reversible blocker. Okay, and you always give those patients who are on the who are on the MAO inhibitor therapy, because whenever they eat the theremin containing food, but they can have this sympathetic hyperactivity, right? And to prevent this, you need to give the patient alpha blockers so that they won't get the sympathetic hyperactivity in case of a MAO inhibitor therapy. Okay, and you will also use these agents to prevent the cocaine-induced hypertension and the vasospasm, because all of them are the alpha mediated. So you need to give the patient phentolamine. And what are the adverse effects? Adverse effects because of a alpha blockage. Now you're going to have a vasodilation, and because of the vasodilation, you can have a orthostatic hypotension, because when you get up, you need to constrict the blood vessels, right, to maintain the same blood pressure. But now this this constriction is not going to happen now, so you will get the orthostatic hypotension, and you will also get the reflex tachycardia because of the beta effect, because of the vasodilation, right? Then comes the alpha selective blockers. Okay, and these are the prazosin, trazodone, tamsulosin, alphilocin, daxazocin. Okay, all of them has this ocin in the ending. Okay, this tamsulosin, it is very much specific for the BPH use only, while the other agent could be used along with the BPH and the treatment of hypertension. So whenever a patient comes to OPD for the treatment of hypertension as well as the BPH, you will give the patient prazosin, trazodone, daxazocin. And if the patient just has a BPH, okay, no hypertension, then you will give the patient this tamsulosin, because it do not have any other alpha effects. Okay, it just stimulate the alpha receptors. It just inhibit the alpha receptors on the sphincters on the urinary bladder, right? But not the blood vessels. While the other agent, they have the effect on the alpha receptors in the blood vessels as well as the alpha receptors in the urinary bladder. Okay, so very much important to know. And just like any other alpha blocker therapy, you will get the orthostatic hypotension, dizziness, and headache. Then comes the alpha-2 selective blocker, and one of them is the mitrazepine. Very much important to know. You will use the mitrazepine in the depression, in the treatment of depression. Very important. You will use the mitrazepine in the treatment of depression. Okay. Sorry about that. Okay, and yeah, that's about it. I think we have discussed every point. Any doubts so far?
How does the phentolamine treats blood pressure in monoamine oxidase inhibitors taking patients?
When the patient is on a MAO inhibitor therapy, and if they eat the theremin containing food, remember the tyrosine, it will be converted into the non-epinephrine, right? So whenever the patient is on the MAO therapy, because the MAO is required for the degradation of the non-epinephrine, okay? So the degradation of non-epinephrine is already inhibited. And if the patient eat this food, then they will get a high concentration of this non-epinephrine, right? So ultimately what's going to happen? The patient will get a hypersympathetic response, a very high sympathetic response. Okay, in order to prevent them, you need to give the patient alpha blocker so that the high BP could be inhibited, right? That's why, to relieve the vasospasms in case of these patients, right?
But why non-selective? Why not alpha selective?
Why not the alpha selectives?
Yeah.
Well, that's a matter of research. I really don't know. And I just know this much only. It's kind of a step 2 stuff, I think, it is more of a step 2 stuff. Why this drug, why not the other ones? I just know this much only, okay? And
Is
one, yeah,
they would inhibit alpha 2 as well, right? Alpha
yeah,
2 does
exactly.
negative regulation, negative feedback. So if
Yeah,
that
exactly.
was inhibited, wouldn't it be more in norepinephrine concentration in synapses?
Even though the non-epinephrine concentration is increased in the synapses, what's going to happen? The alpha is already blocked, right? So alpha stimulation can never be happened. All you will get is the beta stimulation, right? Alpha is inhibited completely. Even though the concentration is increased, what you will get is just the beta effect, not the alpha effects, right? So really don't matter much, okay?
Okay, and the graph you have drawn besides, what does it shows?
What? Please repeat it again.
The graph you have just plotted besides
Okay, we have
phentolamine.
studied. Yeah, we have studied that this graph already. If you go back, just let me go back again. Oh, not on this page. Wait, just a second. Let me show you. Just a second. Just. Remember these graphs?
Yeah.
Yes.
This graph is for the non-competitive or the competitive irreversible inhibitor, right? And this graph is for the competitive reversible inhibitor. So if you give the patient phentolamine, and because it is a competitive reversible type inhibitor, what's going to happen? The potency of the drug will be decreased, okay? But the effect of the drug will remain same. The efficacy will remain same, but the potency will be decreased, right? So that the graph will be shifted to the right. So whenever a question stem describes some kind of a graph who is shifted to the right after giving a drug, that means it is a loss of potency, right? And it could be a case with the, non-epinephrine with the phentolamine. Oh, sorry. Yeah, right. And if you give the patient phenoxybenzamin because it is a non-competitive irreversible inhibitor, what gonna happen? The efficacy would be dropped, and you will get this kind of a graph. Okay. So just stuff for the revision. Okay.
Yeah. Okay. Thank you so much.
And just go back. Okay. And one of the important thing about the mithrazepine, I forgot to tell you, is that this mithrazepine actually increase the appetite of the patient. Okay. Mithrazepine is an alpha-2 antagonist, and it will increase the appetite of the patient. So it can also be used to get the weight gain. Okay. So those patients who are in the depression and they do not eat food much, loss of appetite along with the depression, you mainly use this drug in those cases to get the appetite back, to get the weight gain. Okay. So these drugs can also be used in case of anorexia nervosa. In case of anorexia nervosa, you will use these drugs to get the weight gain. Okay, because they increase the appetite. Okay, very much important.
Is
Then,
that
yeah,
PTSD is post-traumatic stress disorder?
yeah, exactly. Post-traumatic stress disorder. You will use these agents also in case of PTSD.
How
Mostly the
is the
prazosin.
action there?
Yeah.
How is it acting there?
How is that?
What is the action in PTSD?
Of course, alpha stimulations. I really don't know much deeper, but when you study the psychiatric chapter in the FA, you will study that thing. That one of the treatment of the PTSD is the prazosin. Most important treatment for the PTSD. I really don't know the reason for that, but yeah, they just use this drug for the PTSD treatment because it can, it can reduce the nightmares. If you want to know better, this prazosin, it can reduce the nightmares in case of a PTSD. So that's why you can use this drug, okay? To reduce the nightmares. That is the reason. mechanism of action, I really don't know why does it reducing the nightmares, but it reduces the nightmare. Okay, that's
Okay.
all I know. Okay, now the case of epinephrine and the phenylephrine before the alpha blockade and after the alpha blockade. Before the alpha blockade, we already know that epinephrine can stimulate the alpha 1, alpha 2, beta 1, and beta 2. And you will get a predominant beta 2 effect than the alpha 1 effect. So this is a normal scenario we have discussed already. What happens if you block the alpha receptors? Now what you get is the unopposed beta action. And because of an unopposed beta 2, you will get a massive vasodilation. Okay, and because of a massive vasodilation and increase in the the beta 1 effect, what you will get is a reflex tachycardia along with the direct stimulation of the beta 1. So you will get an increased heart rate, you will get an increase in the cardiac output, you will get a vasodilation. And because of all these things, you will get a slightly increase in the systolic blood pressure, a massive drop in the diastolic blood pressure, and what you will get is the drop in the mean arterial pressure, a net depressor effect after the alpha blockade. Okay. Similarly, in case of a phenylephrine, because the phenylephrine is a drug which has the what effect? Phenylephrine, which receptor?
Only
Alpha 1
alpha.
only. Only alpha 1. So what you will get is the increase in the diastolic blood pressure because of a vasoconstriction. Because of a reflex bradycardia and loss of cardiac output and a massive vasoconstriction, you will get a net increase in the systolic BP, okay, and a net increase in the mean arterial pressure, right? But once you inhibit this alpha effect, and this drug, they do not have any beta effect, right? They just have the alpha effect. So the alpha effect is now gone, and what the patient will get, a slight increase in the systolic blood pressure, a slight increase in the mean arterial pressure, a slight increase in the systolic and diastolic, and what you will get is a reflex bradycardia, a very slight reflex bradycardia. Okay, so remember these things. Okay, and yeah, because this is a pure alpha agonist, and it do not have any beta activity, so by inhibiting the alpha receptors, all of the effects of the phenylephrine would be gone, right? And in case of a non-epinephrine extravasation, whenever you give a patient IV non-epinephrine, some of the non-epinephrine could be leaked from the spaces, and ultimately what's going to happen, you will get the vasoconstriction in the blood vessels of the skin, right? So you will get the ischemia, a local ischemia of the area. In order to prevent this condition, you cannot give the patient beta 2 stimulators, because I already told you that in the peripheral blood vessels, the beta 2 are very low, and and the alpha 1s are so much dense in the peripheral blood vessels. So what you need to give the patient is the phentolamine. Okay, so whenever there is a patient who is having this IV non-epinephrine, and he is having this skin pain and ischemia of the area of the IV side, you need to give the patient phentolamine, because the peripheral blood vessels, they do not have the beta 2 receptors, they just have the alpha 1 receptors. And because all of these things are happening because of alpha 1 stimulation, you need to give the patient a local alpha 1 inhibitor, which is the phentolamine, to cause the vasodilation. Okay, understand this fact? Why we are not giving the patient beta 2 receptors? Because they do not have any beta receptors in there, right? Just alpha receptors. Any doubt on this page?
No.
No,
Remember the drug name for the ADSD and the Tourette syndrome?
clonidine.
Clonidine. And for the PTSD, it is prazosin. Okay. Remember the neurological use of all these agents, very important. You will, all these things will be repeated again in the psychiatry. Okay. Then comes the beta blockers. Okay. And beta blockers, all of the beta blockers from A to M, these are the cardioselective beta blockers. They have a beta 1 effect more than the beta 2 effect. All of the beta blockers, which are starting from A up to the M, A, B, C, D, E, F, G, H, I, J, K, L, M, N, M. Okay, all of them are the beta 1 selective. After the M to Z, all of them are the non-selective type. They have both the beta 1 blocker effect as well as the beta 2 blocker effect. For example, the nadolol, the propanolol, the timolol. Okay, all of the selective beta blockers, which have just the beta 1 and the beta 2 blockade effect, they have this olol in their name. Okay, olol. All of the non-selective type blockers, they do not have the OLOL. They have just LOL in their name last, not the OLOL. They have either the ILOL or the ALOL or ZLOL or any other kind of LOL, but not the OLOL. Okay. So for the beta receptors, they have the OLOL. For the beta 1 selective, they have A2M. Okay. N2Z, all of them are the beta non-selective. Okay. And for alpha beta non-selective, they have this ILOL, ALOL, or other LOL, not the OLOL. Okay. That's how it will be very easy for you to understand the name and their functions. Okay. So all the drug A, B, up to here, up to the metoprolol, all of them are the beta 1 selective. This labetalol, because it has A in it, it has both the alpha actions as well as the beta actions, beta blocker actions. Okay, after the metoprolol, the nadolol, navibolol, pindolol, propanolol, timolol, all of them are the beta non-selective type. Okay, and because the beta receptors, the beta 1 receptors, they are found on the heart and the kidney, so they have a most effect on the heart and the kidney for the cardioselective type. Okay. So the first application is the angina pectoris, and because in this case you need to give the patient in that in the heart, so you will always use these agents. Okay. So what actions they do in case of heart? They will decrease the heart rate. Okay, by the beta 1 action, and they will decrease the contractility. Okay, and ultimately they will decrease the oxygen consumption. And because in case of angina there is a supply demand mismatch, the only thing that you need to remember is the supply demand mismatch. Whenever the supply is less or demand is more, okay, or the demand is okay but the supply is less, what you will get is the angina symptoms. Okay, so now what you're going to do, because supply is already less, if you decrease the consumption or the demand of the oxygen, you will get the relief of symptoms. So you use the drugs in the angina pectoris. Okay, and mostly the cardioselective drugs you are going to use. Okay, then comes the glaucoma, because the beta 2 receptors are present in the eye. Okay, and if you inhibit the beta 2 receptors, then the formation of the aqueous humor would be decreased, because the blood supply to the area would be decreased. Okay, so you can give these drugs in the glaucoma treatment, and it is mostly the timolol, the non-selective type. Okay, then for the heart failure, they will reduce the mortality. Why? Because they inhibit the RAS system. Most importantly, they will inhibit the RAS, and RAS is responsible for the cardiac remodeling in case of a heart failure. Okay, so in order to prevent this condition, you need to give those agents which can inhibit the RAS. Okay, like the beta blocker, like the
Metoprolol.
yeah, exactly.
Agonist.
Yeah, exactly. Okay, so all the cardioselective agents should be given: the carvedilol, the metoprolol, the bisoprolol. Okay, because they inhibit the RAS. Okay, and it is responsible for the cardiac remodeling and increased mortality. And you will not give this agent in the acute heart failure. Very important. You will never give these agents in the acute heart failure, because in case of an acute heart failure, you need the cardiac output, you need the contractility, you need the heart rate, right? If you give those drugs, the patient will get the exacerbations of the symptoms, okay, or the severity of the disease. So these drugs can only be used in case of a chronic heart failure, in case of prophylaxis medications, right? Never in case of acute heart failure. Then comes the hypertension.
Why?
All of these,
Excuse me.
yeah.
Why?
Yeah.
Because of pulmonary edema, because it increases the fluid volume.
Because see, if you give the patient these drugs in case of an acute heart failure, then they will decrease the cardiac output, they will decrease the heart rate, right? But in case of an acute heart failure, you need the cardiac output, right? You need the cardiac output. And if you give these drugs, what these drugs are going to do, and they will increase the severity of the disease, right? In case of acute heart failure. So you will never give these agents in case of a acute heart failure, because you need the cardiac output. Okay.
I think also because decreases the contractility, that thereby increasing the fluid backup.
Yeah, exactly. That's why never for the acute, only for the chronic or for the prophylaxis. Okay. Yeah. Yeah. Okay. Then for the treatment of hypertension, because due to the beta 1 stimulation or the blocking effect, you will have the loss of JG cells, you will have the loss of renin secretion, and you will have the loss of cardiac output also. Okay, and if you give the patient non-selective type, then what's going to happen? They will block the beta 2 receptors, like, so what you will get is a vasoconstriction. In case of a non-selective one, you will get the vasoconstriction. Okay, and in case of a selective one, you will get the loss of cardiac output and loss of renin secretion. So mostly the beta 1 selective are given in case of a hypertension treatment, not the non-selective types. Okay, very much important to know. Then comes the hyperthyroidism or the thyroid storm, because all of the symptoms in case of a hyperthyroidism, they are because of the beta stimulations. Okay, so in order to control the symptoms in case of a thyroid storm, you need to inhibit the beta receptors. And what drug will you use? It's the non-selective type beta blockers. Okay, like all the sweating, all the anxiety, all the agitation, all the weight loss, all the heart rate increase, all the hypertension that you will get in case of a hyperthyroidism, it is all because of the beta stimulations, right? So to inhibit these symptoms, you will give the patient beta blockers like the propranolol. Okay, then comes the hypertrophic cardiomyopathy. In case of a hypertrophic cardiomyopathy, the main thing is the restriction of the outflow, right? And if the blood volume is decreased, the obstruction will be increased. We will study that later in the cardio section also. If the blood vessel, if the blood volume inside the heart is decreased, then the obstruction in the outflow of the blood would be increased, right? So in case of a hypertrophic cardiomyopathy, when you give the patient beta blockers, what's going to happen? The heart rate would be decreased. And when the heart rate is decreased, the diastolic time will be increased. And the heart would be filled only in the diastole. So the filling of the heart ultimately increased, the blood volume inside the heart is increased. And once the blood volume inside the heart is increased, the obstruction will be released. And that's why you give the patient beta blockers in case of a hypertrophic cardiomyopathy patient. Okay, very important. Understand this fact? They will ask you why the beta blockers are given in case of a hypertrophic cardiomyopathy, because of the increased diastole time, so that the filling will be increased. Because every symptom is due to the obstruction, on it is because of the low blood volume. Then comes the case of myocardial infarction. In case of a MI, you need to decrease the oxygen demand of the heart. Okay, by decreasing the cardiac output, heart rate, and the contractility. That's why you give the patient beta blockers. Okay. For the supraventricular tachycardia, like I told you, they will inhibit the SA node, and they will also decrease the conduction pathways. Okay, so by decreasing the AV conduction pathway, you can use these agents as a class 2 antiarrhythmics. You already studied that, and you will study that later again in the cardiology section. Okay, then comes the varicose bleeding, very important. In case of a in case of a portal hypertension, what's gonna happen? You will have this a blockage kind of effect, right? And to decrease the venous pressure gradient, you need to give the patient these drugs. They will cause the vasoconstriction. Okay, they will cause the vasoconstriction, so that the blood which is accumulating there could be relieved. So we will use it for treatment of varicose bleeding. Where does the varicose bleeding occur? Anyone?
Due to
Portal hypertension.
Where does the varicose bleeding occurring? What location?
Esophagus.
Esophagus. Yes. To prevent the bleeding in the esophagus, you need to give the patient beta blocker. Okay, so that a dilation could be inhibited and the vasoconstriction can occur in that area. Okay, so nadolol, propranolol, and the carvedilol, always the non-selective agents must be used, not the cardioselective ones. Okay, very important. So what are the adverse effects? Oh yeah.
Is it because of the beta 2 mediated blockade?
Yeah, exactly. Beta 2 blockage. Yes.
Oh.
And one thing is this, and second thing is the RAS system activation, because in case of a portal hypertension, you're also having the RAS activation, right? So by the beta 1 effect, you're inhibiting the RAS, so that the sodium and the water retention, this could be inhibited. And second thing, the vasodilation could also be inhibited, right? So both effects are happening.
Okay.
Both the RAS and as well as the vasodilation. Okay, so what are the adverse effects of a beta blocker therapy? Because you're inhibiting the beta receptors, you will get the bradycardia, you will get the AV block, you will get the heart failure. And that's why I told you, in case of an acute heart failure, you will never use these agents. Okay, in the CNS, you will get a loss of norepinephrine, and the stimulation of beta receptors, you will get the seizures, you will get the sleep alterations. Okay, and like I told you, all the beta receptors, they are involved in the lipolysis. to release the free fatty acids. So once you give the beta blocker therapy, what you will have is the dyslipidemia, right? You will and the beta 2 receptors are present in the lungs. So once you give the patient beta blockers, what can happen is the exacerbations of the asthma or the COPD. You need to be very careful in these patients. You will always use the cardioselective agents in case of a COPD and asthma patient. Okay, always the cardioselective drugs in case of asthma or the COPD patients, because the non-selective ones can cause the exacerbations of the disease. So it could be a case of a patient with arrhythmia, right? It could be a case of a patient with heart failure or other patient or a hypertension patient, and they will ask you what drug is preferred in these patients in case of asthma COPD. They will list on all the beta blocker agents, and the one you have to choose is the cardioselective beta blocker, not the non-selective type. Okay. And because the beta receptors, they are also involved in the insulin release, if you guys remember. Okay. So, the insulin release could be also be inhibited. Okay. And the beta blockers, and the beta, this epinephrine, it will stimulate the beta receptors to cause the release of glucose from the glycogen. Remember the biochem section, the function of epinephrine and non-epinephrine for the gluconeogenesis and the glycogenolysis. Remember?
Yes.
Okay, so if you inhibit the beta receptors, then the epinephrine won't be functioning. And if the epinephrine is not functioning, then what's going to happen? You can have a hypoglycemia, right? Because of loss of gluconeogenesis. Okay, and you will, and if you use the beta blockers in case of acute cocaine intoxication, what you can have is the unopposed alpha stimulation. So you will always want to prevent this thing, avoid the use of beta blockers in case of cocaine intoxications. Okay, and you need to know about these partial agonists, which are the pindolol. Okay, pindolol is a partial agonist. Remember the use of partial agonist. If you use them with the full agonist, what's gonna happen is
Efficacy will drop.
Efficacy will be dropped. Why? Because they are antagonist in case of a full agonist, right? And in case of and in this case, where the stimulation is 0, if you give the partial agonist, what can happen? They will work as the agonist agents. Okay, so only in case of a full agonist, they will work as an antagonist. Okay, and one more thing, if the beta blocker toxicity occur, what drug will you use? You will use the glucagon, because glucagon also function with the cyclic AMP. If you remember the action of this glucagon, you guys will remember that this, the glucagon will work as the GS protein. Remember GS protein, so that it can activate the cyclic AMP. Okay, so the mechanism of glucagon as well as the beta receptors, they are both same. So in case of a beta blocker toxicity, because the glucagon receptors are present in the heart, okay, so you will give the patient glucagon to reverse the toxicity of the beta blockers. Very important. Your heart has the glucagon receptors in it. Okay, so in case of a beta blocker toxicity, because the beta receptors are now blocked. Okay, so the only way to regenerate the cyclic AMP is by giving the patient glucagon. Okay, very important. Okay, and step 1 will also ask you what will happen if you give the patient cardioselective beta blockers. What's going to happen with this peripheral vascular resistance? What's going to happen with the heart rate? What's going to happen with this blood volume? Okay, so in case of a cardioselective, the cyclic AMP in the heart will decrease, so you will get a loss of heart rate, you will get the AV block, you will get the loss of contractility, you will get the ultimately loss of cardiac output. In case of a JG cell, you will have the loss of renin. So ultimately what's going to happen? The blood volume will also get lost. Okay, you will have a decrease in the blood volume in case of a cardioselective beta blockers. Okay, and they have no significant effect on the vascular supply. Okay, and yeah, if you give the patient non-selective cardio blockers and then the beta blockers, what can happen? The cyclic AMP in the heart will decrease, the cyclic AMP in the GG cell will decrease, and as well as you will get the vascular smooth muscle contraction. Very important, you will get the increased peripheral vascular resistance in case of a non-selective beta blockers. Step 1 will ask you. So please remember these facts. Okay, so any doubt? Yeah.
What will we give in hypertension? Non-selective or selective? Selective.
What you were asking? Please repeat it again.
What type of beta blocker will be given hypertension? Selective one?
Both beta blockers will give the hypotension. Ultimate effect is the hypotension.
Hypertension.
No
Yes.
beta blockers can give the hypertension.
No, what is the treatment of hypertension? Selective one or non-selective?
Oh, it depends upon the history of the patient. If it has a history of this COPD and asthma, you will always give the patient cardioselective, right? If the patient do not have any history of asthma or COPD, the main drug is your labetalol. If you guys remember, labetalol use, right? So you can give any drug in this scenario. So depend upon the history of the patient, right? Always. And you guys also remember the symptoms of the hypoglycemia. These are all because of the beta receptors, right? So if you give the patient beta blockers, the symptoms of the hypoglycemia is also masked. Remember?
Yes.
So careful while giving these agents in case of the diabetes patient. And what symptoms cannot be masked in case of a beta blocker therapy? What symptoms of sweating? Why sweating? Because
it is by acetylcholine.
Yeah, exactly. It is not because of the beta receptors, but because of the muscarinic receptors. So sweating would also be there. Hunger could be there, but no other symptoms like the anxiety or the tremors or this high heart rate or other things. Just the sweating and the hunger would be there in case of a beta blocker therapy if the patient develops the hypoglycemia. Okay. So any other doubt on this page?
Yeah, can you come again? You said beta blocker. What symptoms would not be masked?
See, in case of a hypoglycemia, all the symptoms of hypoglycemia are due to the beta receptors, right? So if you give the patient beta receptor blockers, what's going to happen? All the symptoms of the hypoglycemia would be masked. But one symptom, which is the sweating, it is due to the muscarinic receptors, not due to the beta receptors. So the sweating will still be present, hunger would still be present, but all the symptoms like the tremors, like the anxiety, like the high heart rate or the chest pounding, you can say, all of these symptoms are masked. Okay, just the sweating and the hunger would be present in such patients. Okay, so always be careful while giving the beta blocker therapy to the diabetes patient. Okay.
Okay, thank you.
Yeah.
I didn't really understand why you wanted the non-selective for variceal bleeding. I thought that would make
because you want the vasoconstriction as well as the loss of RAS in case of variceal bleeding. So you will give the patient non-selective type so that the beta receptors could be blocked and the patient could get the vasoconstriction. You want to constrict the blood vessels there, right? Because the blood supply is also very much in these vessels. Okay.
What does RAS have to do with it though?
What does have to do with the?
Why would RAS be effective in variceal bleeding?
Because in case of a portal hypertension, what's going to happen? The blood supply would be, in case of a portal hypertension, all the blood will going to accumulate in the portal vessels, right? Okay, and ultimately the circulating blood volume will be dropped. And if the circulating blood volume is dropped, the RAS system would be activated. And what does it going to do? It will lead to the increased retention of the sodium and the water. And all of this sodium and water, it's going to retention in the portal vessels again. So ultimately, because of this vicious cycle, the blood in the portal vessels, it's going to increase and increase and increase. So you want to avoid this condition, and and that's why you need to give the patient RAS inhibitor. First thing. Second thing, you want the vasoconstriction there, and that's why you need to give the patient non-selective type beta blocker, so that both the RAS could be inhibited and this vasoconstriction can happen. You understand that now?
So the RAS is going to keep it from like volume overloading the system and it all getting.
And that's why you get the ascites also.
Oh, okay. That gives you ascites. And then the vasoconstriction is going to help you from bleeding out.
Yeah, exactly. Once the vasoconstriction happens, it will mobilize the blood in there, right? And once the blood is mobilized, it can lead to the inhibition of RAS again. So they're same cycle. Okay, that's why.
That makes a lot of sense.
Okay, so any other doubt on this page? And there's one more drug which you can use for the variceal bleeding, a hormone, if anyone remember the name.
Sandostatin.
Octreotide?
Yeah, exactly.
Somatostatin analog.
Yeah, exactly, because it will inhibit the glucagon and other agents which can cause a vasodilation, right? So you will give the patient somatostatin analogs, octreotide, for the varicose bleeding. Okay, the same
Yeah,
reason.
the other name is Sandostatin, right?
Yeah, exactly. So remember these two drug names, the beta blockers and the somatostatin analogs for the varicose bleeding. Okay. Any other doubt on this page?
No.
No, thank you.
Okay, and then we discussed the phosphodiesterase inhibitors. Okay, the function of the phosphodiesterase in this enzyme, the phosphodiesterase, is to cause the hydrolysis of the cyclic AMP and the cyclic GMP. Okay, what they causes the hydrolysis of the cyclic AMP and the cyclic GMP, and as a result, the effect of this cyclic AMP and cyclic GMP could be reduced. Okay, so you want the phosphodiesterase inhibitors so that the concentration of the cyclic AMP or cyclic GMP could be increased, and as a result, the respective with the respective effects could also be increased, right? So the one drug is the non-specific type of phosphodiesterase inhibitor, which is a theophylline. Okay, theophylline, just like any other drug, they will increase the cyclic AMP concentration in the bronchial smooth muscles mainly. So what you will get is the bronchodilation. So you use this drug for the treatment of asthma. Okay, this thing. And if the side effects occur because it is increasing the concentration of cyclic AMP, in case of a heart, if the cyclic AMP is increased, it can lead to the increase in heart rate. It can lead to increase in the contractility. So what you will get is a tachycardia and as well as the arrhythmia. Okay, and this cardiotoxicity is the major concern in case of a toxicity by the theophylline. Very important. Okay, you can also get the neurotoxicity that can lead to the headache. You can get the abdominal pain also. Okay, and seizures are the most common cause of death in case of a toxicity by the theophylline. Remember, seizures are the most common cause of death, but the cardiotoxicity is the major concern in case of a theophylline toxicity. Okay, and theophylline is one of those drugs which have very narrow therapeutic index. So you need to monitor these drugs very carefully. Okay, and yeah, that's about it. And remember which neurotransmitter or which hormone this theophylline actually inhibits? Which substance this theophylline inhibits, if anyone remember? The coffee and the theophylline. No one? It is the adenosine. Remember now? Adenosine. This theophylline and the coffee, they both can inhibit the adenosine also. Okay, very important. Then comes the phosphodiesterase 5 inhibitors, which have phil in their name, the sildenafil, the vardenafil, the tadalafil, and the avanafil. Okay, what does it do? They will inhibit the hydrolysis of the cyclic GMP so that the cyclic GMP concentration could be increased. And once the cyclic GMP is increased, it will lead to the smooth muscle relaxation by enhancing the nitric oxide activity, because nitric oxide work by the cyclic GMP mechanism. Okay, this nitric oxide increases the concentration of cyclic GMP. Okay, ultimately cyclic GMP will causes the smooth muscle relaxations. Okay, so it can cause a pulmonary relaxation. So you will use these agents for the treatment of pulmonary hypertension. Okay, and you can also use these drugs for the erectile dysfunction. Okay, and you can also use these drugs for the treatment of benign prostatic hyperplasia. Okay, and what symptoms you will get because of the vasodilation? You will get the increased blood flow. So you will get the facial flushing. Because of the vasodilation, you can get the hypotension. Okay, so you will get the heart, and because of dilation of the blood vessels in the heart, inside your head, you will get the headache. Okay, so headache, heartburn, heart, hypotension. These are the side effects of the treatment of these PD5 inhibitors. Okay, and the sildenafil, very specifically, they can cause a synopia or the blue tinted vision. Very, very important. sildenafil, they can cause a synopia or the blue tinted vision. It is because of the inhibition of the PDE6 in the retina. Okay, the PDE6, it is involved in the color vision. If you inhibit the PDE6, you will get the blue tinted vision in case of a sildenafil. So whenever they want to give you a patient on the sildenafil therapy, they will always tell you the patient is having a bluish tinted vision. And whenever they mention this bluish tinted vision, you will immediately know that this must be a case of sildenafil therapy. Okay, very important. You will get the headache, you will get the hypotension, you will get the facial flushing, you will get the blue tinted vision in case of a sildenafil therapy. Okay, you will use these drugs for treatment of pulmonary hypertension, for the erectile dysfunction, and for the BPH. Then comes the phosphodiesterase 4 inhibitor, which is the roflumilast. Okay, and it increases the cyclic AMP in case of neutrophils, granulocytes, and the bronchial epithelium. And because it is increasing the cyclic AMP in the bronchial epithelium, you can use these drugs in the severe COPD. Okay. Then comes the phosphodiesterase 3 inhibitor, which includes the milrinone and the enamrenone. Okay, thus milrinone and enamrenone, they increase the cyclic AMP in the cardiomyocytes. And as a result, when the cyclic AMP is increased in the cardiomyocyte, it can cause the increased calcium influx. We have discussed that already. And once the calcium influx is increased, it can lead to the positive inotropy and positive chronotropy. It can increase the heart rate, it will increase the contractility, right? In the smooth muscles, the cyclic AMP actually inhibits the myosin light chain kinase so that the relaxation of the smooth muscles can occur. It can lead to the vasodilation, so that both the preload as well as the afterload could be increased because of the vasodilation and the venodilation. Because of the venodilation, the preload is decreased. Because of the vasodilation or the arteriodilation, the afterload is decreased. Okay, the heart rate is increased and the cardiac output is also increased to some effect, and the contractility is increased. So you use these agents for the acute decompensated heart failure. Why? Because in case of a heart failure, you need the cardiac output, you need the heart rate, in which these agents are doing, right? And you can also use them in the cardiogenic shock. And what are the side effects? Because they're increasing the heart rate, because they're increasing the contractility, they can cause a tachycardia, they can cause the arrhythmia. Okay, and that's why you won't use these agents in the chronic therapies. They can cause the hypotension because of the vasodilation thing. Okay. Then comes the platelet inhibitors. Okay, because in the platelets, they increase the cyclic AMP, and by increasing the cyclic AMP, they can lead to the inhibition of the platelet aggregation. And the two drugs are the cilastazole and the dipyridamole. Very important. The cilastazole as well as the dipyridamole. Okay, and both of these drugs, they are also the direct arterial vasodilator. Very important. They are the direct arterial vasodilators. Because of the cyclic AMP in the arteries, it can lead to the vasodilation. Okay, these drugs will also increase the concentration of adenosine outside the cell. Very important. They will also increase the concentration outside the cell. Okay, because they inhibit the reuptake of the adenosine by the platelet. So as a result, they will again take part in the vasodilation. So two things: one is the inhibition of the platelet aggregation, and second is the vasodilation. And because they're causing the peripheral vasodilation, these drugs can be used for the intermittent claudication because of the stroke. Once you get this atherosclerosis or kind of a vasospasm in the arteries, you will get the pain on the use of that organ because of a supply-demand mismatch. Whenever you want to use a muscle group, that muscle group needs the increased oxygen supply, right? And this could be done by the vasodilation. But in case of a supply-demand mismatch, the blood supply cannot be increased, but the oxygen demand of this muscle in function would be increased. So you will get the claudication or the pain, right? To prevent that, you will give the patient vasodilator, which is the cilastazole or the dipyridamole. Okay? And along with this thing, you need to give the patient aspirin. Why aspirin? Because these drugs, they will inhibit the platelet aggregation only in the peripheral tissues, right? But in order to prevent the stroke, okay, or the transient ischemic attack in case of a brain, you need to give the patient aspirin also. Because once the patient is having a peripheral atherosclerosis anywhere, the patient can develop the atherosclerosis to other parts of the body also. And to prevent the development of this atherosclerosis in case of a brain, you need to give the patient aspirin. So aspirin along with these platelet inhibitors. Second thing, you will use these drugs for the cardiac stress testing because of the supply demand mismatch. We have discussed this already. If you give the patient dipyridamole, they will increase cyclic AMP in the heart. They will cause the increased contractility, increased heart rate. So the oxygen consumption could be increased. Okay. And yeah. And one more thing is you will study is the just give me a second. Yeah, one more thing you will study in the cardiology section is the coronary steal phenomena or the coronary steal syndrome. That can be happen if you give the patient arterial dilators, like in case of a dipyridamole. Okay, so the blood supply to the actual organ which is under the ischemia would be decreased, but the blood supply of the other areas of that organ is increased, and as a result, you will get the exacerbations of the symptom. So you will use these drugs in the cardiac stress testing also. Okay, and for the coronary stent restenosis, you will use these drugs also for the acute therapy only, not for the chronic therapy, because shortly after the stent placement, the vasospasm can occur in that area, right? And in order to prevent the vasospasm or the restenosis, you need to give the patient these agents for the short duration of the time. Okay, and what are side effects? It includes the nausea, headache because of the vasodilation in the head, the facial flushing because of the vasodilation and increase in the blood supply, the hypotension because of the vasodilation, and the abdominal pain. Okay. So whenever you get a peripheral artery disease or atherosclerosis anywhere inside the body, like in case of limbs, hand, and the feet, you will always give the patient silastazole for the symptomatic management. And you also need to give the patient aspirin or the clopidogrel to prevent the secondary atherosclerosis formation in any other part of the body, right? That's why aspirin with the dipyridamole. And this silastazole is also a phosphodiesterase 3 inhibitor. Okay. And the dipyridamole, they inhibit the uptake of the adenosine in the platelet so that this adenosine concentration can be increased in the blood vessels, and it can cause the vasodilation. Very important. Okay, so any doubt on this page so far?
No.
Oh, thank you.
Then you need to know about the toxins in the seafood. Okay, and all of these toxins can either increase the sodium channels, can cause the activation of the sodium channels, or they can inhibit the sodium channels. Okay. First is the histamine, which is found in the dark meat fish, like the tuna, mahi, and other fish. You don't need to remember the name of these fishes. Okay. But once you get the histamine, you can get the symptoms like the anaphylaxis. You will get the vasodilation. You will get the facial flushing. You will get the itching. You will get the bronchoconstriction, bronchospasms. You will get the angioedema. You will get the hypotension. Okay. Facial flushing, itching, erythema, bronchospasm or the respiratory distress, angioedema, and the hypotension. Whenever you encounter a patient with these symptoms after eating some kind of a fish, you will immediately know that it is because of the histamine. Okay, and what is the treatment? Similar to that of the anaphylaxis, it would be the epinephrine or the albuterol to prevent the respiratory distress. Okay, and after giving these drugs only, you can give the patient antihistamines. Okay, so step 1 will list you the antihistamines also in the option, but you won't choose the antihistamines. You need to give the patient epinephrine first or the albuterol first in case of anaphylaxis like symptoms. Okay, then comes the tetrodotoxin, okay, which binds to the fast voltage gated sodium channels and they prevent their depolarization. Very important, they prevent their depolarization. Okay, so as a result, the sodium channels can never be activated, can never be opened. What you get is the loss of reflexes because the nerves, the nerve would transmit, this transmission is now inhibited. The action potential is inhibited. So what you will get is the hyporeflexia, the paralysis, the loss of sensory inputs, paresthesias you will get. Okay, and nausea, diarrhea, other things. Then comes the singvatoxin. Singvatoxin actually opens the sodium channels too much. So ultimately you will get the paralysis, but the hyperreflexia. Very important, you will get the paralysis, but the hyperreflexia in this case because of a too much activation of the sodium channels. Okay. You will have a reversal of the hot and the cold symptoms. You will get the numbness, diarrhea, nausea, vomiting. Every symptom is same, but you will get the hyperreflexia in case of a syngotoxin. In case of a tetrodotoxin, you will get the hyperreflexia. Okay, so this tetrodotoxin, they will block the sodium channels, the total block of the sodium channels, and the syngotoxin, it can cause the depolarization of the sodium channels. Very much important to know. Treatment is only supportive. Any doubt on these toxins?
It is written it causes depolarization, sigma-toxin, but it
Yeah,
causes
exactly.
heart blocks. How does it causes heart blocks if it causes depolarization?
Because of too much activation, remember? Once a too much activation occurs, it can lead to the desensitization ultimately.
Yeah,
And because of this desensitization, you will get all these symptoms. The the paralysis with the hyperreflexia. Why? Because of the desensitization of the receptors, right? And you will get the heart block also.
What about the cardiac effects of tetrodotoxin?
The cardiac effects of a tetrodotoxin, it is inhibiting the sodium channels, and you require the sodium channels for the generation of the action potential. So again, you can get the heart block, but it is not a major effect in case of a tetrodotoxin, right? You can get it, no doubt, because it is inhibiting the sodium channels in the heart also. Okay.
Okay.
Okay, then comes the Beer's criteria. It includes all those agents which you need to avoid in the old age groups. Okay, the first are the alpha blockers, which can cause the increased risk of orthostatic hypotension. So you always need to avoid the alpha blockers. Okay, the anticholinergic agents, all these anticholinergic agents, they can cause the glaucoma or the increase in the intraocular pressure in case of an old age patient. So you always want to avoid the anticholinergic agents in the old age. So any agent which has an anticholinergic property, like the antihistamine agents, antidepressants like TCA, or these the benzodiazepine drugs. Okay, you always need to avoid these agents in case of a old age patient, right? Then the benzodiazepines, because they increase the sedation and the delirium, you need to avoid these agents as well. NSAIDs, they can increase the risk of GI bleeding, okay, and the peptic ulcers. Okay, so you need to avoid these drugs in the old age patients. The PPIs, remember I told you when we're discussing about the cause and difficult infection that the PPIs are a very important cause of the C. difficult infection. So you need to avoid these agents as well. Okay, so whenever you got any old age patients, you always want to avoid these agents. So step one will list you a certain list of the agents, like for a sleep aid pills. If the patient is asking you for a sleep aid pill, so the step one will list you certain drugs like the benzodiazepines, like the other Z drugs, or the antihistamine drugs, or the melatonin agents. So you need to choose a melatonin agent, right? Because they have a very less risk of delirium and the sedation. Okay, not the benzodiazepine, not the antihistamine, not the TCAs. Okay, they should be avoided in the old age patients. So I hope you understand this thing, how these questions can be framed on this paragraph. Okay, any doubts so far? Okay, so now we discussed about the different toxicities and side effects of certain drugs and how you would treat these conditions. Okay, so first, in case of acetaminophen toxicity, how does the toxicity of acetaminophen occurs? Tell me.
Increase in NAPQ.
In case of, yeah, the
I think it's mitochondrial dysfunction. An oxidative injury.
Yeah, exactly. An oxidative injury by the generation of yeah, exactly. And what enzyme is involved?
Cytochrome P450.
Cytochrome P450, yes. So yeah, so acetaminophen will cause the free radical damage in your liver, right? And as a result, to prevent the toxicity of this acetaminophen, you need to give the patient an acetylcysteine. Why? Because this N-acetylcysteine will replenish your glutathione, and glutathione is required to fight the reactive oxygen species, right? So an acetylcysteine. And what is the name of the of this toxic metabolite of the acetaminophen, which is formed after a cytochrome P450?
NAPQ.
Yeah.
NAPQ. So
Yeah, exactly.
N-acetylactic acid.
Yeah, good, very good. Then for the acetylcholinesterase inhibitors or the organophosphate, you first need to give the patient atropine. We have discussed that, and then you will give the patient this pralidoxime. Okay. Third, for the anti-muscarinic agents, you always give the patient physostigmine. Why? Because it inhibits both the both the symptoms in the brain as well as outside the brain, right? That's why the physostigmine. Then for the arsenic toxicity, remember what does this do? The toxin do?
Angiosarcoma.
Yeah.
Angiosarcoma.
Yeah. Okay. Angiosarcoma is okay,
It
but the
inhibits the
toxicity.
mitochondrial complexes.
Not the mitochondrial complexes. Any specific name? Pyruvate dehydrogenase complex. Remember? Remember pyruvate dehydrogenase complex? It is inhibited by the arsenic. Yeah.
Yes.
And what symptoms you would get? Any specific odor?
Garlic.
Garlic breath odor.
Step 1 will always mention this thing. The patient will always have a garlic odor in the breath. Okay. And because arsenic has a R in its name, so all the drugs like dimercaprol, saxamer, they both have R in their name, right? So dimercaprol and saxamer for the arsenic toxicity. Then comes the benzodiazepines, and the drug you will use is a flumanesyl. What kind of interaction it is? The competitive or non-competitive?
It's competitive.
Exactly. Then for the beta blockers, you can use the glucagon, which is a first-line drug. Then the atropine and the saline also given. Okay. Then for the carbon monoxide poisoning, you need to give the patient 100% oxygen. Okay. And what does this carbon monoxide do in the body, in the RBCs?
Forms methyl hemoglobin.
It will form the
carboxyhemoglobin.
Okay. And second thing, this is the first thing. Even though the oxygen is available for the patient, yeah.
It shifts oxygen hemoglobin dissociation curve to the left, so decreases
And
the
in other cells.
It inhibits oxidative phosphorylation.
Yeah, exactly. Which?
Complex
Yeah, exactly.
4.
Which complex? Complex 4.
Complex
Yes.
4.
Please remember the fact. Okay, it inhibits a complex 4 also. Okay, which step of the complex 4? The passage of the electron from cytochrome AA3 to the oxygen. Okay. Step 1 will mention you this with this reaction, and they will ask you which reaction is inhibited. So it is a passage of electron from cytochrome AA3 complex to the oxygen. This part is inhibited by the carbon monoxide. Okay. So even though the oxygen is available, you cannot utilize this oxygen for the generation of ATP. Okay. Very much important. For the copper, you use the penicillamine. Okay. Very much important, penicillamine for the copper. And the Wilson's disease, for example, treatment of the Wilson's disease, the penicillamine. Okay. Then for the cyanide poisoning, you need to give the patient hydroxycobalamin. Okay. It will combine with the cyanide to form the cyanocobalamin. Okay. What does this hydroxycobalamin known as? Cobalamin. Remember?
Vitamin B12.
Vitamin B12. Yes. You will also give the patient thiosulfate so that this sulfate group could be donated to the cyanide and it could be easily excreted from the body. You can always give the patient nitrite to convert the hemoglobin in the methemoglobin, right? And this cyanide will readily bind to the methemoglobin and it could be easily excreted after that. Then for the digoxin poisoning, you give the patient antibodies. Okay, and if the antibodies are not available, you can also give the patient magnesium. Okay, very important to note. Then for the heparin, you need to give the patient protamine sulfate. Do not confuse with the warfarin. For the toxicity of warfarin, what you would do? For the warfarin toxicity, what you would do?
Vitamin K.
Vitamin K. And for the acute?
FFP.
Fresh frozen, yeah, exactly. Fresh frozen plasma. Okay, please remember this thing. And for the iron overload, you need to give those drugs which have Fe in their name, deferoxamine, and this deferriprone. Okay, so every drug has this Fe in its name. Okay, for the lead, you can give any drug like the EDTA, dimercaprol, penicillamine, Saxaimer. Okay, and for the mercury, you will use these drugs which have R in their name, the dimercaprol and the Saxaimer, same as the arsenic poisoning. Okay, for the antifreeze like the methanol and the ethylene glycol, you will use the drug fomepizole. Remember what this drug do? Fomepizole, which enzyme it inhibits?
Alcohol dehydrogenase.
Aldehyde, yeah. Aldehyde dehydrogenase, okay.
Alcohol dehydrogenase.
Oh yeah, sorry, alcohol dehydrogenase. Oh, I'm sorry about that. Alcohol dehydrogenase. Okay, and you can also use the ethanol. Why the ethanol can be used?
The competitive inhibitor.
Yeah, exactly, for the competitive binding to the enzyme. And as a result, these drugs or these agents or these toxins can never be bind to the alcohol dehydrogenase. Okay, for the methemoglobin, you use the methylene blue and the vitamin C. Okay, because vitamin C is a reducing agent, like I already discussed. It will convert the Fe3 plus into the Fe2 plus form, if you remember. Okay, so that the Fe2 plus can be absorbed from the GIT, right? So it is a reducing agent. Okay, so you use this for the treatment of methemoglobin. For the opioids, you will use the naloxone. Okay, and you need to give the frequent doses of the naloxone. Very important. You need to give the patient frequent doses of the naloxone because naloxone is a short-acting agent. Step 1 will ask you. Okay, and then the salicylate poisoning. For the salicylate poisoning, you need to give the patient sodium bicarbonate. Why sodium bicarbonate? Because salicylates are the weak acid. And if you increase the pH of the environment, then these weak acid can be converted to their ionized form and they can be easily excreted in the kidney. Remember the PK and the pH?
Yes.
Don't forget that, okay? And for the TCA poisoning, which is the cardiac and the coma and the convulsions, the triple C, the cardiotoxicity, coma and the convulsions, you will use the sodium bicarbonate. Why? To basically provide the sodium to the cardiac cells, okay, to stabilize the cardiac cell membrane. Then for the warfarin, we have discussed the vitamin K for delayed effect or for the chronic therapy, the PCC and the fresh frozen plasma for the immediate effect. Okay, any doubt on this page?
No.
Okay, so we are going to skip next 2-3 pages of the first aid because it's nothing, just the side effects, all the listed side effects of certain drugs. Okay, so nothing too much, understand, just the thing for revision. Okay. Then we need to know about the cytochrome P450 interactions. Most important thing. Step 1 will give you a drug and they will give you another drug and they will ask you what's going to happen to this, to the concentration of this given drug. Okay, and also they will give you the name of 2 drugs and they will ask you, and they will give you whether the therapeutic failure is going to occurring or the toxicity going to occur. So you need to know which drugs inhibit the cytochrome P450 and which drugs activate the cytochrome P450. And ultimately these inducers and as well as these inhibitor, they will control the level of these substrates. Very important. These inducers and these inhibitors, they will control the level of these substrates, which are the warfarin, the theophylline, the OCP, the statins, and the antiepileptics. Okay, so step 1 will list you 3, 4, or 5 drugs in a same question stem, and step 1 will ask you why the toxicity of this drug is occurring. It is because of this drug or this drug or this drug or this drug. So you need to choose the drug which has the action on the cytochrome P450. Okay. So first comes the inducers. Okay. All the CNS agents, all these drugs which act on the central nervous system, okay, like the anti-epileptic agents, all the neuropsychiatric drugs that you will study, all of them are the inducers of the cytochrome P450. Okay, the chronic alcohol use is the inducer of cytochrome P450, and that's why if you give the patient acetaminophen to a patient on the chronic alcohol therapy or this alcoholic patient, what's going to happen? The toxicity of the acetaminophen will occur because it is metabolized by the cytochrome P450. Okay, very much important to know. St. John's wort, it is also inducer of the cytochrome P450. Okay, rest all drugs that you know, the rifampin and and two antimicrobial agents, the rifampin and the graciofulvin, which is an antifungal agent, and this is a antibacterial agent. Okay, and rest all CNS drugs, these are the cytochrome P450 inducers. Okay, no need to learn the individual names. Just need to learn, in which category these drugs come. Every CNS drug that you study, it is a cytochrome P450 activator. The two antibacterial agents, which is a rifampin and the graciofulvin, these are the activator of the cytochrome P450. Every other antimicrobial agent is an inhibitor of cytochrome P450. Okay, and the St. John's wort is also an activator. Okay, so anti-epileptics, alcohol, and two antimicrobial agents. These are the activators. Then comes the inhibitors. Every antibiotic that you know, it is a cytochrome P450 inhibitor. Okay, every GI drug that you know, like the cimetidine or the proton pump inhibitors, these are the cytochrome P450 inhibitors. Okay, and the grapefruit juice, very important. The grapefruit juice is also an inhibitor of the cytochrome P450. It would be a patient who is a certain therapy like the warfarin, and the patient also uses the grapefruit juice, and now the patient is having a therapeutic failure. So step 1 will ask you why the therapeutic failure is happening in this patient. So the answer would be the use of grapefruit juice because it inhibits the cytochrome P450. Okay, and one CNS drug, which is the sodium valproate, very important. One CNS drug, which is a sodium valproate, it is an inhibitor. Rest all CNS drugs are the activator of the cytochrome P450. Okay, so sodium valproate, the isoniazid is antibacterial. Cimetidine, which is in the GI tract, you study the ketoconazole, fluconazole, antifungal agents, alcohol, acute, the chloramphenicol, antibacterial, erythromycin, antibacterial, sulfonamide, antibacterial, ciprofloxacin, antibacterial, omeprazole, which is a proton pump inhibitor, metronidazole, antibacterial, amiodarone, okay, which is antiviral, okay, and the ritonavir, which is antiviral, the grapefruit juice, all of them are the inhibitor. So no need to learn the individual name, just learn the categories. It would be very much easier for you to understand that. Okay, and all of these drugs, they will control the level of the warfarin, anti-epileptics, theophylline, and the OCPs. Okay, and one more drug is the statin. So whenever the step 1 will give you a history of a patient who is having a muscle pain or the hepatotoxicity, and they will also list you 3 or 4 drugs again, and they will ask you why the toxicity, or why these symptoms are occurring. So it would be due to the interaction between the statins and these inhibitory agents. That kind of a questions step 1 can frame. Okay, so any doubt on this cytochrome P450 interactions?
Yeah, I have a question. You
Yeah,
said
please ask.
all CNS drugs are inhibitors except valproate. But
Yeah.
under the inhibitors, valproate is number 1.
What are you asking? Please repeat it again.
You said
Your
all
voice is not clear.
CNS drugs. You said
Yeah.
all CNS drugs are inhibitors except valproate. But
Yeah.
under the inhibitors, you put valproate as number 1.
If you can please write in the
Maybe
chat
you
box.
should write activator, not inhibitor.
I'm not
So is there a
understanding.
mistake?
If you can
All
please
CNS
write in the
drugs-
chat box.
Actually,
Right.
says
what
that
you are
all
saying,
CNS drugs are
Uh,
inhibitor. But you said all CNS drugs are inducers.
all
On the
CNS
top
drugs are
right.
inducers. Yes.
Right. But you
You
have written
just
down
wrote,
all CNS drugs are inhibitors.
inhibitor.
It should be inducers.
Okay. Don't just. Okay. So all the CNS drugs are the inducers except the sodium valproate, which is an inhibitor. Now is it okay?
Yes.
Yes, but
Thank you for
you write
correcting me.
yourself inhibitor.
Yeah. Thank you so much for correcting me.
Inducer.
Yeah. Okay. Any other doubt?
Yeah.
Ask, please. Any doubt?
Yes.
Please ask.
do we have to remember this drug interaction of specific drugs like of warfarin, theophylline, and OCPs? Like OCPs has interaction with anti-tuberculous drugs, etc. Do we need to
You just
remember?
you just need to remember the categories. I told you, because it's, the name of the individual drug would be so much long. As you can see, there are so many drugs to remember, right? But if you remember the category of the drugs, like antibacterial, anti-GIT drugs, and all these drugs in the CNS, so that's why, in that way it would be very easier for you to remember. Okay, so you just need to remember the category of the drug, okay, not the whole name, because it would be so much longer process. Okay, just the category would be enough. Whenever you encounter a drug which is a CNS drug, you can immediately know that this must be the inducer type agent, right? Not the inhibitor type agents.
So one antiarrhythmic drug is inhibitor, amiodarone.
Yeah, amiodarone is also it has two functions. I think amiodarone is also antiviral drug, right?
No, it's antiarrhythmic.
Antiarrhythmic, and as well as, if I'm not confusing that.
No, amiodarone is antiarrhythmic, class 3.
Yeah, it is antiarrhythmic, no doubt, but it just give me a second. Let me clarify my doubt.
It is not
I'm
viral.
not confused. Yeah,
it is
just
not
a
viral.
Just a second. Just give me a second.
I'm sure it's not viral.
Oh, it is amantadine, not the amiodarone. I'm sorry
Yes,
about that.
exactly.
It was amantadine. Yeah, it was amantadine. Sorry about that. Yeah, it is also a antiarrhythmic agent, and it is a cytochrome P50 inhibitor. Yes.
Yes.
Yeah. Sorry about that. I got it misconfused. It was amantadine who was the antiviral, not the amiodarone. Okay.
Yeah.
Okay, so these classes you must remember, not the individual names. The antibacterial drugs, the antifungal drugs, the proton pump inhibitors, okay, and this cimetidine, okay, which is a serotonin drug. So all of these drugs are the inhibitors, while the CNS drugs, these are the inducers. Okay, that's all you need to know. And remember these 5 names: statins, warfarin, antiepileptics, theophylline, and OCPs. The question always gonna revolve around these drugs. Okay, either the therapeutic failure of these drugs or the toxicity of these drugs. Okay, so interaction always associated with these drugs only. Any other doubt?
What is it that about amantadine?
Amantadine?
Antiviral for flu.
Okay,
Amantadine,
inhibitor.
Yeah, amantadine is not an inhibitor, not an inducer, and most importantly, if you want to list it, then amantadine could be the inducer. Why? Because it is a CNS agent. You use this for the treatment of Parkinson's. Remember?
Yes.
It could be inducer, but it is neither the inducer nor the inhibitor. Amantadine. Okay. I think that's about it. And the sulfur drugs, you don't need to remember any of this shits. Okay. Okay, so we have finished the pharmacology completely, the general pharmacology part and the autonomic drugs. Any doubts so far? Please ask.
Amantadine for both flu and Parkinson's disease, right?
Yeah, exactly. Amantadine for both flu as well as the Parkinson's disease. I was thinking about the amiodarone as the antiarrhythmic as well as antiviral, but it was amantadine, not the amiodarone. I got it confused. Sorry about that. Yeah, exactly. Okay, I hope this chapter is very much clear to you guys.
Yes.
If any doubt, you can ask me again. We can wait for another 5 minutes and then we will start the biostats.
That's okay. Thank you.
So you just need to remember, for this chapter, how you can remember everything is by the kind of organization way, If you read this chapter in an organized way, it would be very much easier for you to understand everything. Okay, like organizing the drug in the basis of the organs, the receptor on the basis of the organs, and the drugs for like the beta selective, then the beta non-selective, then the alpha beta non-selective, and then the alpha selective. So if you study these drugs in this way, then it would be very much easier for you to understand and to learn everything in these pages. Okay. Okay, so we have done with the autonomic drugs, and now we're going to study the biostats. I think we can take a short break of 5 to 7 minutes. Okay.
Sure.
Then we will meet again.
Okay.
Yes. Thank you.
Okay. Okay, so we're going to skip this observation studies part for now because it is kind of too much conceptual, and it is very much harder to study it like just a reading of the first aid. So I will make the separate slides for it, a perfect slide where I will discuss everything that you need to know for these studies. Okay, so for today we're going to skip this part. Okay, and I will make the perfect slides for it to make you and to make you understand better these things. Okay, so just wait for the tomorrow. Okay, everyone agrees?
Yes.
Okay, so now comes the practical. Someone's mic is on. Just give me a moment. Okay, it's mine only. Okay, so two type of studies are there actually. One are the observation studies, okay, and second are the experimental studies. We're gonna skip the observation studies for now, okay, and now we're gonna go to the experimental studies. Okay, one of the experimental studies is the clinical trials. Okay, for the clinical trials, okay, you whenever you want to test a drug, a certain drug is came into the market, right? And before it came into the market, it always need to go through these 4 phases. Okay, and now we're going to discuss these 4 phases. Okay, so in the first phase of the clinical trial, okay, you will always need some healthy volunteers. Okay, you will always do this experiment on the healthy volunteers. So whenever a step 1 question statements describe a certain experiment in which a drug is being tested on the healthy volunteers, whenever they mention the word healthy or normal individuals, that means it is always the phase 1 trial. Okay, but in case of a cancer drug, you cannot just give the cancer drug to a healthy volunteers, right? So in case of a cancer drug, you will always use the diseased patients. But in all other drugs, you will always use the healthy volunteers. Okay, this is the phase 1 of the trial. You will test the drug on the healthy volunteers. And what things you're gonna test the drugs for? First is the safety. What is the safety levels of the drug? What is the toxic level of the drugs? What is the pharmacokinetics? How the drug is going to eliminate from the body? Okay. What is the pharmacodynamic of the drug? How the drug function in the body? How the drug is eliminated from the body? Okay. What is the safety profile of the drug? What is the toxicity level of the drug? What are the side effects of the drug? All of these things you're going to study in the phase 1. Okay. Then comes the phase 2. Now, from the phase 2, phase 3, and phase 4, you are always going to use the drug in the diseased individuals or the individuals with the disease of interest. In the phase 2 part, you will use a moderate number of a patient, like 100 or 150 individuals, let's say. Okay, you will give the drug to these patients, and you will check for the adverse effects. Again, you will check for the efficacy, whether a drug is beneficial or not. Okay, you have checked the drug is functioning. Now, whether a drug is beneficial or not, you will use this in the phase 2. Okay, what is the dosing required to get the effects? Okay, so what are the effects, what are the dosing, and what are the side effects? All of these things you're going to study in the phase 2. So in the phase 2, you will ask a question to yourself whether the drug is beneficial or not, whether the drug is actually functioning for the disease or not, right? In the third phase, you're asking a question whether the drug is more important, or kind of have a better kind of, what you can say, is more beneficial than the drug which is already in the market. So in the phase 3, you will compare your drug. Okay, in the phase 1, you have tested your drug, the way it works. In the phase 2, you have asked whether the drug is functioning or not. In the phase 3, you are comparing the drug with the previous treatments. Okay, so always in the phase 3, you will have 2 group of patients. Okay, one which is receiving the new therapy, and one which is receiving the previous therapy or the placebo. Okay, so in the phase 3, you will always has two groups. It will always be a large number of patients with the two groups. One group is receiving the new treatment, and the other group will be receiving the placebo or the previous treatment. And you will now compare the effect of the new drug with the previous treatment. Is there any improvement or not? Is the new drug is more beneficial than the previous drug or not? Right? In the phase 4, it is always a post-marketing surveillance. Very important. Phase 4 is always a post-marketing surveillance. Okay, and it will always detect the rare side effects or the long-term side effects of the drug. Okay, so phase 4 is a surveillance study. Okay, it will always detect the long-term side effects of the drug or the black box warnings that you know. Okay, so for the phase 1, you will test it always on the healthy volunteers, and you will ask a question whether the drug is working or not. Okay, what are the side effects of the drug? What are the properties of the drug? You will study in the phase 1. Whether the drug is beneficial or not, whether drug has certain efficacy or not, you will assess that in the phase 2. In the phase 3, you will ask a question whether a drug is more beneficial or more have a much more improvement than the previous good therapies or not. You will always use a large number of patients with two groups. One is the group which is receiving the treatment, and one is the group which is not receiving the treatment. Okay, and you will give them the placebo. And then comes the fourth phase, which is a post-marketing surveillance study that will detect the long-term side effects of a drug. Very important. And how you can improve your randomized clinical trials. How you can improve this? First thing is by the randomization. You will randomly distribute the patient into a group 1 or a group 2. Okay, no bias should be there. It will always be a random. Okay, it should be a double-blinded, so that neither the patient nor the doctor who's giving the dose knows which patient belongs to which group. Okay, sometimes it could be also a triply blinded, in which the analyzer of the data, even he doesn't know what patient receives what therapy. Okay, so it should be a randomized, it should be controlled, it should be a double blinded, which means neither a doctor neither a patient knows which patient receiving what therapy. Okay, very much important. This is a clinical trial. So step 1 will give you a scenario. They will give you a number of the patient, or they will give you a healthy volunteers, or they will ask you about the surveillance study, and they will ask you finally what phase is in the what phase in the drug now, either the phase 1 or the phase 2 or the phase 3 and the fourth and the phase 4. So you need to aware of these phases. And they will also ask you how you can reduce the bias of the study, which is by the randomization, by the blinding. Two things are very important. Okay, yeah, so that's about the clinical trials. Okay, now then you need to know about the diagnostic test and their properties. Okay, first two things that you need to know about is the sensitivity and the specificity. Okay, sensitivity is how much sensitive the test is in detecting a certain disease. Okay, with how much power a certain test can detect a disease process. Okay, it could be a real disease process, or it could be a chances of having a disease. Okay, which means whenever a test is positive, whenever a test which has a very high sensitivity get a positive, it not always means the patient is having a disease. It might be a false positive. But the most important thing to recognize is the fact that they can never leave a patient with the disease. Okay, so a good sensitive test would be a test which have very high sensitivity, which means every patient who has the disease, the test should be able to identify those patients. Okay, and so that whenever a test has a very high sensitivity, it means you can easily rule out those patients which do not have the disease. Right, you're understanding the fact? Whenever you have a very high sensitivity, that means the test is always detecting all these individuals which are having the disease, which means if the individual do not have the disease, then the test must be negative always. Right, so a high sensitivity test is always good at ruling out the disease. Right, and for a specific test, it tells a property of the test to detect a certain disease very accurately, which means all those patients who do not have the disease, all these patients which have the disease, the test must be identified them. Whenever a test become positive, whenever a specific test become positive, it always means the patient having the disease. The 100% chances that the patient is having a disease. Okay, and wherever a sensitive test become negative, it is the 100% chance that the patient is not having the disease. So a high sensitive test is good at ruling out the disease, and a high specific test is good in ruling in the disease. You cannot rule out the disease on the basis of a highly specific test because it can always give a high false negative, right? And both these sensitivities and specificities, they are the fixed property of a test. Please note the fact, both of them are a fixed property of the test. They cannot change with the, with the prevalence of a certain disease in the population. Okay, it is always fixed for a certain test. Doesn't matter whether disease is prevalent in a certain population or not. Okay, sensitivity and specificity are very fixed for a certain test. Okay, so we understand the sensitivity and specificity.
Yes.
Okay, so now, and then you need to understand this table. Okay, let us suppose there is a patient who is or a certain group of patients. Some of them are actually having the disease and some of them are actually not having the disease. Now you apply your test on those individuals and you either get the positive result or you get the negative results. If you get the positive result in those patients which actually have the disease, then it is called the true positive. Okay, which means the patient are having truly positive. Both the test as well as disease identify this. Okay. If the patients do not have the disease and your test call it positive, then it means it is a false positive. Okay. And then again, if you have the disease, I truly have a disease, but the test calls it negative, that means it is a false negative. Okay. If the patient does not have the disease and the test calls it negative, that means it is a true negative. Okay. Then you need to know about the sensitivity, which is a true positive rate. What are the chances of getting a true positive result is known as the sensitivity, a proportion of all the individuals with the disease who are tested positive, or the probability that when the disease is present, the test is positive. Okay, the test only detects it. So whenever a high sensitive test calls a disease negative or calls an individual negative, that means the patient is not having the disease. You can easily rule out the disease. Okay, a value when approaching 100, you can easily rule out a certain disease. Okay, because every sensitive test has a very low false negative. Very much important. Every sensitive test has a very low false negative. Okay, so percentage of all the individuals who have tested positive are the true positive. And what is the sensitivity? How you can calculate it? It would be the total number of true positives among all the patients which are having the disease. Okay, so rate of true positive among the individuals which are having the disease, which means the true positive and the false positive, this column. This is your sensitivity. Okay, sensitivity is basically detecting a process of disease process in all the individuals who are actually having the disease, right? This is it. Then comes the specificity, which is the proportion of all the individuals without the disease who are actually tested negative. Okay, so the proportion of all the people who are without the disease and who have this test negative, which means the true negative, which means the patients who are truly negative, and among the patients who are actually negative. So all the patients which are negative, it will become in this part, and all the individuals which will be tested negative by the test, they will come above. Okay, so it is a true negative rate. Okay, the chances of true negative among all the individuals who are negative for the disease, this is the specificity. Okay, so once yeah, ask.
Sorry to interrupt you. Can you please record the lecture?
I think the recording is on already.
It is recording already.
Yeah, it is recording already.
Sorry.
Yeah.
Sorry,
Okay.
sorry.
Okay, no problem, right? Okay, so a highly sensitive test is always used as a screening test. Okay, whenever the step 1 will ask you a question why a certain test is not a best screening test, they will give you a certain scenario, a disease, and they will give you 2-3 test list, and they will give you the fact that this test is not in a use as a screening. So step 1 will ask you why this certain test is not good for a screening purpose. So you will always answer because of a high false negative rate or a very low sensitivity. Okay, so a screening test should be a test which will detect every disease process, even the individuals which do not have the disease process. Okay, because you do not want to exclude those individuals which are actually having the disease. You always want to rule in every patient with the disease, right? So a screening test is always the test which has a very high sensitivity, because you always want to rule in every patient who has a disease, so that you can easily rule out those individuals which are not having the disease, right? So high sensitivity for a screening test. Okay, and a test with a high specificity must be used after the confirmation with the screening test. Once you confirm that patient is having a positive screening test, you will use a specific test on him or her, and then you will confirm the presence of a disease process. So first screening test or the highly sensitive test, then comes the specific test used for the confirmation, right? Then the two things, which is the positive predicted value and the negative predicted value. The positive predicted value actually asks a question: if I have the test a positive, then what are the chances that I am actually positive with the disease? Okay, I am tested positive for a disease. Now, what are the actual chances that I am having the disease? This is a positive predicted value. It is always dependent upon the prevalence of a certain disease in the population. Let us suppose there is a population which has a very high prevalence of a certain disease, and then the patient came to a department and he got tested positive for the disease. So what you can say about the patient, that there are very high chances, because disease is very prevalent and you actually get a positive result. That means these are very high chances that you are actually positive, right? And this is a positive predicted value. And let us suppose there is a population in which there is a certain rare disease, and now a patient comes to your OPD and you test the patient for the disease, for the rare disease, and the patient got a result positive. Now, what can you say about this patient's result? Because the disease is very rare and the test is positive, you can say that there are very low chances that you are actually having the disease, and there are very high chances that this could be a false negative, right? So the positive predicted value actually tells you that when a patient tested positive, what are the actual chances that the patient having a disease? Okay, it could be calculated by all the positive scenarios, which means a true positive divided by the true positive with the false positive. Okay, whenever the prevalence of a certain disease is high in a population, that means the positive predicted value is very much high for a test, right? Because there are very much high chances that the patient is actually having the disease, because the prevalence is already very high in the population, right? And whenever the prevalence of a certain disease is low in a population, that means even though the test is positive, there are very low chances that the patient is actually having the disease. Okay, so positive predicted value increase with the increase in prevalence and decrease with the decrease in the prevalence of the disease. You understand this fact now?
Yes.
Okay, now comes the negative predicted value. It will tells you when a patient tested negative for a certain disease, then what are the chances that the patient actually do not have the disease. Okay, and let us suppose there is a population in which there is a certain disease which is highly prevalent in the population, and if the patient got a result of negative from this population, so tell me, the patient can have a very high false negative rate also, because the disease is very much prevalent in the patient. So there are very less chances that the patient is actually having a disease negative. Understand that? Okay. Understand that?
Yes.
No.
Okay.
Yes.
Okay, so let me repeat it again. The negative predicted value actually tells you when a patient tested negative for a certain disease, then what are the chances the patient actually is negative from the disease. Okay, let us suppose there's a disease which is highly prevalent in a population, and a patient from that population came to a department and he's tested negative. But because the disease is so much prevalent in this population, that means there are very few chances that the patient is actually negative, even though he's tested negative for the disease. Okay, there are very few chances that the patient is actually negative because the disease is so much prevalent, right? But when a patient, in which when a patient is belong to a population in which a certain disease is very much rare, a rare disease, and the patient tested negative for that disease, that means there are very high chances that the patient is actually negative for that disease, right? That means we can say that the negative predicted value increases with the decrease in prevalence and decreases with the increase in prevalence. If the prevalence is too much, then there are very few chances that the patient is actually negative. If the prevalence of a certain disease is very less, that means there are very high chances that the patient actually not having the disease, right?
Yeah, for example, COVID in India, if somebody comes to the outpatient and if they're tested negative, but prevalence is high in COVID in India, so high.
That means it is a very high chance that it is a false negative, very high chance that it is a false negative, right?
Yes, yeah.
Even I got the COVID and I got a result of negative, but I was having symptoms, every symptom for like 10 days, but my test was negative. So it must be a false negative test. Okay. So that's how this positive predicted value and negative predicted value correlate with the prevalence of a certain disease in the individuals. Okay. Understand these two facts now, these two terms, very much important to know.
Yes.
Okay. Now see, there is a test. Okay. Like say for an enzyme level, okay, for the myocardial infarction, you have a test for the myocardial infarction and you want to detect the level of troponin. And you say like, if the patient has a troponin level of above 100, that means the patient is having a myocardial infarction. And if the patient is having a level of troponin below 100, I will call it a patient without a myocardial infarction, right? We have discussed this scenario, right? Okay, now what's gonna happen in some individuals, they are having the myocardial infarction even at a 90 level of troponin. And in some individuals, they are having the myocardial infarction not even at the 110 or 120. Okay, so what's gonna happen? Let me annotate it for you. Let's say you have discussed, you have decided a certain level for the troponin enzymes, that above this level, all the individual will be tested a positive for the myocardial infarction. Let's say 100 level of the troponin, a hypothetical scenario, right? All the patients which are having the troponin level above the 100, they will be positive for the myocardial infarction. And those individuals which are having below the level of 100, they will be tested negative for the myocardial infarction. But then there are certain individuals which are having the troponin of 90. Okay, but with the 90 level of troponin, they're having the myocardial infarction. And there are certain group of individuals which are even having the level of like 120, 130 or 140 of the troponin. Even though they have a very high troponin, they are negative for the myocardial infarction, actually negative for the myocardial infarction, right? So two things could be happen. These are all the patients without the MI. Okay. And these are all the patients with the MI. Now, as you can see very clearly, there are certain individuals which are having a troponin level of greater than 100, but they are negative for the myocardial infarction, actually negative. And there are certain individuals which are having a troponin level below the 100, but they are having the myocardial infarction. They have the positive myocardial infarction, right? Understand this thing up to now?
Yes.
Yeah.
Okay, now you have created a cutoff value. So now what's gonna happen? This is the cutoff value, okay? Whenever you test an individual for the MI, if he have the MI greater than 100, if you have the troponin level above 100, you will test him a positive. But all these individuals without the MI, which have the level of greater than 100, they also tested a positive with the disease. That means all the individuals which fall here, they are all the false negative. Oh, sorry, false positive, right? And all the individuals which have the troponin level below 100, but they're actually tested negative, but they have the MI, but the test gives them the negative. That means all these individuals are the false negative, right?
Yes.
Okay, now all these individuals which have the troponin level greater than 100, and they also have the MI. That means this population, they're all the true positive, right? And all the individuals which have the troponin level less than 100 and they do not have the MI, they are the true negative, which means this population, right? All this population. So this true negative, true positive, false negative, and false positive, they correspond to here. Now, what's gonna happen if you increase the cutoff value of a certain drug or of a certain test? Let's say not the 100, but I want to set a cutoff value for 120. That means all the individuals which have the troponin level greater than 120 will be tested positive, and all the individuals less than 120 will be tested negative. Now, what's gonna happen? My false positive rate, it is gonna down, and it would be down now, because all the individuals which do not have the myocardial infarction but they have the troponin level greater than 100, they will be tested negative now, right? So what's gonna happen? My false positive rate, it will be getting down if I increase the cutoff value, right? But at the same time, my false negative rate, which means all the individuals which have the level of this troponin below 120 but they actually have the disease, they will be tested negative by my test, which means my false negative rate will be increased, as you can say. So whenever I increase the cutoff value, my false positive rate, it will be decreased, and my false negative rate, it would be increased. And similarly, when I decrease the cutoff value, my false negative rate, it will be decreased, and my false positive rate, it will be increased, right? And if I decrease the cutoff value for, say, here, I've taken the cutoff value to here, which means I can detect every individual which is having the disease, as you can see. Now I can detect every individual which is having the disease if I decrease the cutoff value. And if I am detecting every individual who is having the disease, that my test will have a very high sensitivity. I can say that, right?
Yes.
Yes.
Okay, because I'm detecting every individual with a disease process, I can say that my test will have a very high sensitivity. But at the same time, I'm getting a very high false negative rate. As you can see, I'm getting a very high false negative rate here. Okay, so if I decrease the cutoff value of a certain test, then I am increasing the sensitivity of the test, right? But at the same time, because I'm increasing the rate of false negativity, false positive rate, that means I cannot say that my test is actually a very specific test, right? Because for a specific test, the test must be good in ruling in the disease, right? You guys understanding this fact?
Yes.
Yes.
Okay, that means whenever I decrease the cutoff value for a certain test, what's gonna happen? My sensitivity will increase and my specificity will decrease. Okay, and whenever
Why does specificity decrease?
see, what does a specificity mean? Tell me.
Ruling in a disease.
Ruling in the disease means my test should be able to detect every individual with the disease. It should never left any individual without the disease. Sorry, I'm saying it opposite. I'm sorry about that. A specific test is good in ruling in the disease, which means it will give you a very high false negative rate. Okay, understand that? You will get a very high false negative rate in case of a good specific test. Why? Because my test is actually detecting a disease process, but at the same time, when the specific test gets a positive, then I can be 100% sure that this test that this patient is having a disease. But once my specific test gets a negative, I cannot 100% say that this patient is not having the disease, because it could be a very high chance that the patient is having a false negative. Okay.
Okay.
See, in this case, if I decrease the cutoff value from here to here, then I'm increasing the chances of detecting every individual with the disease. But at the same time, I'm also increasing the false positive rate. As you can see, this is all the false positive rate, which is very much increased, right? So how can I say that my test is specific if I'm getting this much false a false positive rate. If I'm getting a very high false positive rate, then how can I say that my test is a very specific test? Because if my test is get a positive result, I can be certainly say that this individual is a positive for the disease. But in this test, I'm getting a very high false positive. That means the specificity of my test is very much low, right?
Yes. Yeah, I got
So
it.
whenever I decrease a cutoff value for a certain test, then I'm detecting every individual with the disease, right? I can easily rule out those individuals without the disease, right? But at the same time, I'm compromising with my specificity because now I'm getting a very high false positive. That means I cannot say whether this patient 100% is having a disease or not, right? So whenever I decrease a cutoff value, I will always increase the sensitivity, but at the same time, I'm decreasing the specificity. Okay. And similarly, when I increase the cutoff value for a certain test, let us say I've taken the cutoff value to at C point here, then as you can see, I'm detecting every individual with the disease. Okay. So whenever my test get positive, I can be 100% sure that the patient is actually having the disease. But whenever my test got negative, because so many individuals with the disease, they're going to test negative with the disease, right? I cannot 100% say that the patient is not having the disease, right? So whenever I increase a cutoff value, I'm getting a very high specificity and a very low sensitivity. Okay. Understand these facts now? Let me clear every point.
Yes.
Whenever I increase a cutoff value, I'm getting a very please just a second.
Hello.
Okay, so whenever I increase a cutoff value, I will increase a specificity, but I will decrease the sensitivity. Whenever I decrease the cutoff value, I'm increasing the sensitivity and I'm decreasing the specificity. Okay. And at the same time, my negative predicted value, which means the chances that I'm actually negative, if I decrease a cutoff value, okay, and my test got negative, then these are the very high chance that I'm actually negative for the disease, right? I'm actually negative for the disease if the test got negative, because it is including every individual without the disease, but not including any individual with the disease if my test got negative. So that means it is a very high chance that I'm actually negative for the disease, which means if I decrease the cutoff value, then my negative predicted value, this will be increased, right? And if and at the same time, the chances of being actually positive, this will decrease because it is a very high false positive. As you can see, all these individuals are the false positive. And if a test has a very high false positive, and then I cannot certainly say that this patient is not having the disease. Sorry, this patient is having the disease, right? That means my positive predicted value will decrease if I decrease a cutoff. And similarly, if I increase a cutoff for a test, then I can say that the patient, if I increase a cutoff value for a certain test and the patient get a positive result, like say from here, and if the patient got a positive result, just a second, if the patient got a positive result, which means here, then I can say that 100% chances are there this patient is having a disease, which means a good positive predicted value. But if the test who got a negative result, which means this scenario, then there are very high chances that it could be a false negative. A very high chances that it could be a false negative, which means a very low negative predicted value. So whenever I increase a cutoff, I will get a very high positive predicted value and a very low negative predicted value. Whenever I decrease the cutoff, I will get a very high negative predicted value and a very low positive predicted value. Now you guys understand this graph and this correlation?
Yes.
Any doubt?
No.
Okay, just a second again. Now comes the likelihood ratio. Okay, and let us suppose there is a patient come to emergency department with a chest pain. Okay, and you tell that there are 50% chances that the patient is having a myocardial infarction. Then you run some tests and the test came out to be positive. Okay, now because you already have a very high chance of being hema positive, And these tests again adds up some chances in your diagnosis, right? So you are increasing the chances of the individual being a positive. This is the likelihood ratio positive. Okay, whenever a patient comes to your department for a certain disease and you give him a chances of getting a positive, okay, then you run some tests and the patient actually got a positive result. So this will increase the probability of the patient of having the disease. This is a likelihood ratio. Okay, the likelihood that a given test result would be expected in a patient with a targeted disorder compared to the likelihood that the same result would be expected in a patient without a target disorder. Okay, you already know that the patient having a chest pain, which means this is a very high chances that the patient is having a myocardial infarction. And above that, when you run the tests like the ECG and the troponin, and the patient got this ST segment elevation or the high troponin level, then you can be a very certainly say that this patient is actually having the myocardial infarction, right? This is the likelihood ratio. It is always given to a certain test before the test is being done in a patient. Understand it now?
Yes.
Okay. So for a positive likelihood ratio, you just need to know the formula for now. Okay. You don't need to go in much detail, just know the formula. They will give you certain values of a sensitivity of a test or the specificity of a test, and they will ask you what are the positive likelihood ratio or what are the negative likelihood ratio. Okay, so for the positive likelihood ratio, it would be a sensitivity divided by 1 minus the specificity, which is the true positive rate divided by the false positive rate. Okay, let me show this again. See, the sensitivity is also known as the true positive rate, and 1 minus sensitivity is the false negative rate. Okay. Similarly, the specificity is also known as the true negative rate, which is means all the true negative divided by all the individuals without the disease. Okay. So individuals who got tested with the test negative divided by all the individuals without the disease, which means the true negative rate. Okay. And 1 minus specificity similarly is the false positive rate, which means all the individuals who are tested positive which actually do not have the disease. This is the false positive rate. Okay, similarly LR negative, it would be 1 minus sensitivity divided by specificity. So sensitivity always gonna go up, and sensitivity and the specificity is always below. Okay, in case of LR positive, it would be sensitivity 1 minus specificity. In case of LR negative, it would be 1 minus sensitivity upon the specificity. Okay. And the likelihood ratio, it does not depend upon the prevalence. It's just the chances that you're already given to a certain patient of being a real positive. Okay. And once a test came out to be positive, how much with the surety you can say that this test is actually a positive, because you're already given him a chances of being a positive. That is known as a likelihood ratio. Okay. Very important. Then just give me a second. Any doubt in it in the likelihood ratio?
No.
I have a question.
Yeah, please ask.
When you're gonna calculate like likelihood ratio positive, is the same if I get the true positive and false positive, just use this formula?
Yeah, exactly.
So I can do either way, right?
Yeah, you can do either way.
Okay, thank you.
Exactly. Okay, so let us suppose ask.
I have to ask something. Yeah, this LR positive ratio greater than 10 and less than 0.1. Please explain this thing.
Okay, so if the LR positive is greater than 10, which means you are saying very, with a very high chances that the patient is actually having this. And like say, for example of myocardial infarction, the patient came into a department with a chest pain, with a severe chest pain. Okay. So now you are very much sure that the patient is having a MI. Okay. Above that, you run a test and the test came out to be positive. That means you can 100% with the 100% surety, you can say that the patient is actually having the disease. Okay. Because you're already very much sure, and above that, the test is also positive. Okay. Now you can be 100% sure that the patient is actually having the disease. And whenever I am 100% sure that the patient is actually having the disease, I call it a very high specificity, right? So whenever LR positive came to be more than 10, it indicates a high specific test. Okay. You got it now?
Yeah, and LR negative.
In case of a LR negative, let us suppose I got a patient with, with some kind of a chest pain, and I'm not very much sure if it is a chest pain for the MI or not. Okay. And then what happened? I run the test, and the test came out to be positive. But in actual, the patient is not having the disease. I was very sure, okay, because it was a different kind of chest pain, not the chest pain with the MI, but the test is calling the patient positive, which means I can certainly say that this test has a very high sensitivity, but not the very high specificity. The test is calling the individual positive, okay, but the individual is actually having the negative. The likelihood that I have given to the test was very much low already, because I was sure the patient is not having the disease. I was very much sure before he came my department. And when I ran the test, it got a positive result. But I was sure the patient is not having the disease. So I can say that LR positive, whenever the LR negative is less than 0.1, or whenever the likelihood ratio is very less for a certain test, that means a test is a sensitive test. Okay. It's just it's all about the probabilities that I'm giving to a certain test. How much confidence I'm having in this test. It is all about that. If the patient is having a disease symptoms completely and the test got a positive, then I can be highly confident that the test is a real positive. Okay. If the patient is having a very few symptoms, and even after that the test came out a positive, then I can be for my very high chances say that this test is not kind of reliable for this thing, or the test is actually a false positive, right? So it is all about the LR negative and LR positive. Okay. You understand it now? Okay. So whenever
Yes.
okay, so now whenever the question is time gives you, okay, of a certain patients, the chances of the patient being up having the disease, or chances of the patient not having the disease, and they ask you for, let's suppose let us suppose they will give you a table of a certain age groups, okay, and the prevalence of a certain disease in these age groups, like for in case of 1 to 10 years old, the prevalence of a certain disease is like 10 among 100, the 10%. In case of a 20 to 40 years old individuals, the chances of having a disease is like 30%, and similarly so on. And if the step will ask you that one patient from 1 to 10 age group, two patient from 20 to 40 age group, and three patient from a 40 to 80 age groups came to a department, then what are the chances that none of them will have the disease? Okay. So it could be the 1 minus probability multiplied by the number of individuals for different probabilities. I will show you an example tomorrow. Okay. Don't worry about that. I will explain this concept with a example tomorrow. So just wait for some time. Okay. I will skip it. I'm skipping it for now. Okay. Is it okay with everyone? I'm skipping this for now. I will come back to it with an example. Okay, because it's a very good concept. And yeah, so whenever a question asks you why a particular test is not good for the screening, then answer must always be the low sensitivity. Okay, do not get confused. Okay, then comes the quantifying risks, which means the odd ratio, the relative risk reduction, or the attributable risk and everything. Okay, let us suppose there is a patient or a group of patients which are having the disease or not having the disease, or certain outcome, not just a disease, but a certain outcome. Okay, you have given an experiment or an intervention. Okay, and like a risk factor, it could be anything, like you have given to a certain environment to a certain patients. Okay, and those patients in which you have given the environment or an intervention, those got the disease or the outcome, then you will call it a. Okay, if the patients, even after giving the certain environment or an intervention, they do not develop the outcome, you will call it a B, for example. Okay. And for the individuals you did not give the environment and they developed a certain outcome, the same outcome without the environment, you will call it a C. Okay. And you have not given any environment to the patient and they do not develop any outcome, okay, then you will call it a D. Okay. So now comes the risk ratio and the odds ratio. What is the risk? First say, what is the risk? You have given a certain intervention or a certain environment and the patient got the outcome. Okay, let it be a risk factor. For example, smoking. Okay, you have given smoking to a certain group of individuals, a certain number of individuals, and out of all the smoking individuals, some of them got the cancer and some of them do not got the cancer. Okay, so those who develop the outcome or the cancer, I will call them A. Those who do not develop the cancer, I will call them B. So what is the risk in the exposed group or this group? It would be A, or the total number of individuals with the cancer and divided by all the individuals with the intervention, with the exposure. Okay, so the individuals who develop the outcome divided by all the individuals who got the environment or got the intervention. Similarly, risk in the unexposed group will be equal to all the individuals who developed the outcome or the disease divided by all the individuals who do not get the intervention or the environment. Okay, is it clear up to now? The risk thing, is it clear up now, guys?
Yes.
Okay, now comes the relative risk. Okay, so relative risks are basically what is the chances, okay, what are the risks of getting the disease in the exposed group as compared to a group without exposure. Okay, what are the chances or what are the risks of getting a disease in the exposed group as compared to those groups who do not get the exposure. Okay, because both the exposed group and the non-exposed group, they both get the outcome, as you can see. Okay, even if you do a smoking or you do not do a smoking, you will get the cancer, lung cancer, right? But what are the chances that the patient who is having the smoking, they will get the lung cancer? So it would be the relative risk. Okay, and how you will calculate it? It would be the risk in developing the exposure, risk of of getting the outcome in case of a exposed group divided by the risk of getting the disease or the outcome in the non-exposed group, which means A divided by A plus B divided by C upon C plus D. So this is the relative risk. If the relative risk came out to be 1, which means the risk in the exposed group will be equal to the risk in the non-exposed group. And that means a certain exposure is not, is not contributing in any way in the developing of the disease process. That means there is no association between the exposure and the disease. Okay, if I got the relative risk of more than 1, that means the chances of having a disease in the exposed group is more than the chances of having a disease in the non-exposed group. That means my exposure or my intervention is actually contributing in some way to the disease process. Okay, that means the exposure is associated with the disease occurrence. Okay, if I got the relative risk or of less than 1, that means a certain intervention like a drug therapy is actually decreasing the risk of having the disease. That means the risk of having the disease in the exposed group for, like, say, a vaccine or a drug, okay, is less than the individuals without the exposure or without the intervention. Okay, is it clear for you guys, the relative risk? Is it clear?
Yes.
Yes.
Okay, and where would you use the relative risk? It is always used in the cohort studies. Very important. It is typically used in the cohort studies, because in the cohort studies, you will first identify the individuals with the exposure status, and then you will follow the individual for the disease outcome, right? So first you have given them the exposure, and then you will check whether they develop the disease or not. Okay, similar to that, you will give the patient any exposure or the intervention. Then you will check whether the patient developed the outcome or not. So the relative risk is for the cohort studies only. Okay. Then comes the odd ratios. It is basically defined as what are the chances of having a certain exposure, okay, in the disease group and in the non-disease group. Okay, what are the chances of having the exposure? See, in the relative risk, you're getting the chances of having the disease in the exposed or non-exposed group. But in the odds ratio, what are the odds or what are the chances of having a certain exposure or the intervention in the disease group and in the non-disease group? Okay, so for example, in case of a diseased group, which is this group, what are the chances of individual or being a smoker? Okay, this would be A. Okay, and what are the chances of not being a smoker? This would be C. Both of them get the lung cancer, but what are the chances of actually having a smoking status? This would be A by C. Similarly, in a non-diseased individual, what are the chances of individual being a smoker? This would be B upon my D. So our odds ratio will be A upon my C divided by the B upon my D. Okay, so it is basically represents the odds or the chances of having a exposure in the disease group as compared to the non-diseased group. Okay, you understand the odds ratio now?
Yes.
Yes.
Okay. Yeah, very good. So FA also given some example in case of a case control, and you mostly use the odds ratio in the case control studies only, because in the case control studies you first identify the individual with the disease and then you will check for the exposure status, right? So you're actually checking the chances of an individual having the disease, of having the exposure status. And that's why the odds ratio is for the case control study and the relative risk is for the cohort study. Very important. Okay. And let's go for the example. Let's say in case of a case control study, 20 out of the 20 individuals are having the smoking status and 30 cancer patients are not having the smoking status. Okay. Out of the 30 individuals, the 20 are not having the 20 are having the smoking status. Okay. And out of the 25 individuals which do not get the cancer, 5 had the smoking status. So what are the odds ratio in that case? It would be the 20 upon my 10. The chances of being a smoker, which is 20 by 10, and the chances of not being of the smoker, and you get the cancer. Similarly, the 5 by 20, which means in the non-diseased group, the chances of being a smoker and not being a smoker. So what you will get is the 20 upon my 10 divided by 5 upon my 20. You will get the odds ratio of 8. Okay, that means of every individual who are having a lung cancer, okay, it is 8 times. These individuals are having 8 times more chances of having a smoking history. Okay, understand it now? That means these are the chances of being a smoker in case of a lung cancer is 8 times than the normal individuals who got the cancer but no smoking history. Okay, you understand the odds ratio now?
Yes.
Okay. Then comes the relative. Yeah, ask.
No, I was saying that I understood.
Okay, good to know that. Okay, so now comes the relative risk reduction. The name itself suggests a relative risk reduction, which means the reduction in the risk as compared to the original risk. Okay, the relative risk reduction is basically the the reduced risk as compared to the original risk. Okay, which means the absolute risk reduction divided by the placebo or the original risk. Okay, for example, if there is a 2% of the patient who receive a flu shot develops a flu, which means out of the 100 individuals who got the flu shot, 2 individuals got the disease. Okay, and out of the 100 patients who do not get the flu shot, 8 individuals got the disease. So what is the risk reduction? This would be the 2 by 8. How you can say that? Let me make a table for you. You don't need to memorize every formula. Just the name is enough. Okay. Let's make a 4x4 table, 2x2 table. Okay, so these are the individuals who got the intervention or the flu shot positive. These are the individuals who do not get the intervention, flu shot negative. These are the individuals who got the disease, which means got the flu positive. And these are the individuals who do not get the disease, which means flu negative. Okay, so out of 100 individuals who got the flu shot, which means these individuals, okay, 2 of them got the disease, okay, and rest 98 of them, they do not got the disease, right? Similarly, out of those individuals who do not get the flu shot, 8 got the disease, okay, and remaining 92, they do not get the disease. Okay, so what is the risk? What is the relative risk? This would be the 2 upon 100 divided by 8 upon 100, right? Which is means the risk in the exposed group divided by the risk in the non-exposed group. Okay, so the risk reduction would be our how much? 2 upon 100 divided by 8 upon 100, which means would be the 0.25, right? Or if I say what would be the absolute risk reduction, it is not relative. What would be the absolute risk reduction? That would be the minus thing. Okay, which means 8 upon 100 who got the 8 by 100 who do not get the flu shot divided by minus 2 by 100 who got the flu shot. This would be the absolute rate reduction. So I can say the absolute rate reduction will be equals to the 8 upon 100 divided by 2 upon 100, right? And when I want to know about the relative risk reduction, then I want to compare it with the all individuals who have the risk of developing the disease when they do not get the flu shot, which means the absolute risk reduction divided by all the individuals who do not get the flu shot, or I can say the placebo maybe. You understand this formula? Understand this formula?
Yeah.
Okay, so let's calculate now. Okay, so what is the absolute rate reduction? This will be the 8 upon 100. Okay, minus it is 2 upon 100. What would I get? This will be equals to 6 upon 100, right? Okay, 6 upon 100 is my absolute rate reduction. Okay, I want to compare it with the placebo, the risk, or I want to compare it with the risk in those individuals who who do not receive the flu shot, which means 6 divided by 100 divided by 8 divided by 100. Okay, this will be equals to 6 upon 8. Okay, 6 upon 8 will be equals to 0.75. This is the one way to calculate it. And the FA mentioned a formula that the relative risk reduction will be equals to 1 minus the risk reduction, which means if I got the relative risk, let me clear my drawings. Okay, the relative risk in this case would be the 0.25. Okay, and for the relative risk reduction, it could be 1 minus 0.25, or I get the 0.75. So you can do in both the ways. Okay, whichever is kind of easy for you, you can go with that. Okay, if you go with the name, the relative risk reduction, that means a risk, the absolute risk reduction divided by the risk in the non-exposed group. Okay, and if you want to go for the FA formula, then this would be equals to the relative risk reduction equals to 1 minus the RR. Okay, both ways I can get the answer. Okay, and you want to know how the FA got this formula? If anyone want to know, I can teach him. Please respond. Okay, so let me drive this for you. Okay, I will turn on my camera. Okay. Okay, see, what I told you is the relative risk reduction. This will be equals to absolute risk reduction divided by the risk in the original group, right? Now, what is the absolute risk reduction? This will be equals to the risk in the non-exposed group or those who do not take the flu shot minus the risk in those individuals who receive the flu shot or the exposed group. And in the denominator, I will take all the individuals who won't get the flu shot or without the exposure, who are not exposed. Okay. I can write this thing as risk in the non-exposed group divided by risk in the non-exposed group minus the risk in the exposed group divided by the risk in the non-exposed group. Can I write it like that?
Yes.
Okay, so what I got now is 1 minus what is the risk in the exposed group divided by risk in the non-exposed group? Tell me.
Relative
The
risk.
risk in relative risk. So you can either write the relative risk reduction as 1 minus my relative risk, or you can use this formula, the original formula. Okay.
Okay.
Is it clear to everyone now?
Yes.
Yes.
Okay. If you just understand the basic formula, you can drive it, with the help of it very easily. So just you need to know the name. A name itself is enough. The relative, not the absolute. Okay. So that's how you can go for it. Okay, let's get back to the screen again. Then comes the attributable risk. Okay. And what risk you will attribute to a certain intervention or a certain exposure, okay, as compared to all the other interventions, which means, let me show you just a second. Okay, so attributable risk is basically a difference in the risk between the exposed group and the non-exposed group, which means the absolute rate reduction or the absolute increase in the risk. Okay, this is just a difference between the risk in the exposed group and the risk in the unexposed group, which means you are saying very absolutely that this this much chances you are giving to a certain intervention for developing the disease process. Okay, for example, as in this case, the risk of getting a lung cancer in the smokers is 21 and the risk of getting a lung cancer in the non-smokers is 1. So how much chances you are actually attributing to the smoking? This would be 21% minus 1, which is the 20%. Okay, and if you go back and look at the relative risk reduction, I have told you that the relative risk reduction is basically the actually reducing the risk divided by the placebo, right? So this absolute thing could be the this. Sorry, I got it confused with the absolute risk reduction. Just wait for that, okay? Before we come back again here. So you guys understand the attributable risk? Forget the later part. You understand the attributable risk? The actual chances of of a smoker being of having a lung cancer, of developing a lung cancer would be your attributable risk. The chances you're giving to the smoking. Okay, and if the step 1 asks you a attributable risk percentage, okay, then this would be equals to the absolute increase in the risk or the attributable risk divided by the risk in the smoking population or the exposed group. Okay, and after so it would be a risk in the exposed group minus my risk in the unexposed group, okay, which is the attributable risk divided by the risk in the exposed group. And similarly, if you take these terms very separately, then the risk in the exposed group divided by the risk in the exposed group, it would be come out as 1. Okay. And the risk in the unexposed group divided by the risk in the exposed group, this would be equals to 1 upon my relative risk. See, let me write it down for you, because you need to know how these formulas are derived ultimately, right? So risk in the exposed group minus में risk in the non-exposed group, right? This would be your attributable risk. And if they ask you a percentage of the attributable risk or kind of a relative increase in the risk, this would, in this case, you will have to divide it with the risk in the exposed group. Okay. So I can write it like 1, because this whole term will be called as 1 RE upon my RE, minus I can write it like 1 upon my risk in the exposed group divided by risk in the non-exposed group. Can I write it like that? This whole term, I can write it like that, right?
Yes.
Okay, so what I get now is 1 minus, what does the risk in the exposed group divided by risk in the non-exposed group known as? Relative risk. So I will get 1 upon my relative risk, right? And if I can go back again and can write it like as can I write it down like write it like as? Is it right?
Yes. Yes.
Okay. So that's how you get the attributable risk percentage. Okay. So whenever a step 1 asks you the attributable risk, you always need to, minus the 2 terms, the risk in the exposed group and the risk in the unexposed group. Okay. And whenever they ask you attributable risk percentage, you always have to divide it with the risk in the exposed group and multiply it with the 100. Okay. Both way you can achieve the answer. If you do not want to learn every formula like that, so you can just go with the names. The name itself, who tells you the formula of the certain term. Okay. Then comes the absolute risk reduction. It is same as the attributable risk. The risk, the decrease in the risk. In case of the relative risk reduction, what I did is I have divided the attributable risk with the placebo or the original risk. Okay. And in case of an absolute risk reduction, you just need to minus them. For example, out of the 8% populations or 8% of the people who receive the placebo, they develop the flu. Okay. And the 2% of the people who receive the flu vaccine, they do not, they develop the flu. So what is the absolute risk reduction? This will be equals to 8 minus 2, which is the 6%. This is the attributable risk. Sorry, absolute risk reduction. And when the step 1 asks you the relative risk reduction, you need to just divide it with the 8%. Okay, so 6% by 8%, this will come out to be the 0.75% similarly. Okay, so with one single formula, you can target both the conditions, both the terms very easily, right? Then comes the number need to treat and the number need to harm. The number need to treat is basically a inverse of the absolute risk reduction. Okay, lower number of the number need to treat will be a better treatment, which means you need to treat, like for example, there is a drug. Okay, and with the help of this drug, if you treat like 100 patients, then you can correct 1 patient from the drug. And then there is a drug B. Okay, and for the drug B, if you treat like just 50 patients, okay, then you will get a 1 patient completely treated with the disease, completely free of the disease. Okay, so tell me which drug is better, either drug A or drug B?
Would you repeat the question?
Yeah,
okay, so
repeat the question.
my question was, I have a drug A and I have a drug B. Okay, for the drug A, I need to treat 100 patients before I get a beneficial effect in 1 patient. Okay, And for the drug B, I need to treat just 50 patients before I get a one beneficial effect in one patient. So what drug is better, drug A or drug B?
Drug B.
Drug B, right? So
Yeah.
lower the number need to treat will be a beneficial treatment, a better treatment, right? So number need to treat will be equals to 1 upon my attributable, 1 upon my absolute risk reduction. Higher the number would be a poor treatment. Lower the number would be a better treatment, because you need to just treat few patients to get a beneficial effect in one patient. But if you have a very poor treatment, then you need to treat at least 1,000 or 2,000 patients before you get a beneficial effects in one patient, right? So that's what the term means. Then comes the number need to harm, which is the inverse of the of this attributable risk. Okay, and it is basically higher the number. If you have a higher number need to treat, that means it is a safer exposure, which means you need to expose more number of patients before you get a disease in one individual. Okay, that means higher the number need to harm means a better or a safer exposure. You understand these two terms now?
Yes.
Okay, and then comes the case fatality rate, which is all the deaths which are occurring among all these individuals who are having the disease. For like the COVID, you're having a death cases, you're having a total number of cases. And if you want to calculate the case fatality rate, then this could be equals to the death divided by cases multiplied by the 100. Okay, this is the case fatality rate. Then comes the hazard ratio, which is same as having the relative risk. So they will either tell you the relative risk or they will mention the term hazard ratio. Do not get confused. Okay, hazard ratio just tells you the effect of a certain intervention over a time. Okay, how long would, whenever a step 1 will ask you a question that how long will it take for the event to develop the disease. Okay, there is an exposure, and after the exposure the event happened. So how much time is required to get the outcome after a certain exposure is given? It is calculated by the hazard ratio. This hazard ratio will tell you how much time you require to get the disease once the exposure is given. For example, the 5-year survival rate of of a risk or a control group. So this 5-year term that you are saying, it is by the hazard. It is by the hazard ratio. Okay, so it will just tell you how long will it take to develop the outcome once the exposure is given, and the formula is same as that of the relative risk. So if they ask you to get the to calculate the hazard ratio, you can easily calculate it. And if they ask you a question, then how will you calculate the time take to develop the disease? So you will calculate with the help of hazard ratio. Do not get confused. Okay, very easy thing. Okay, so any doubts so far on this page?
Yeah, that a rare disease in which the odds ratio is equal to the relative risk.
I was about to come here. See, in case of a rare disease, because all the individuals which are having the disease, they're kind of very much rare. Okay, that means like for say, all the individuals without the disease like 10,000 or 1 lakh. Okay, and the individuals with the disease like for A, it is an individual with the disease with the exposure even. Let's say it is just 1 or 2. So you can easily neglect a 1 or 2 number in before 1 lakh or 2 lakh, right? So for the A plus B, I can easily say that A plus B can can approximately be equal to just the B. Okay, I can write with 10 lakh 1,000 as with 10 lakh only, right?
Yeah.
Okay, so I can say A plus B equals to B, and I can also say that C plus D will be equals to D, because the D is a much higher number than the C. Okay, now let's calculate the relative risk in these individuals. The relative risk will be equals to A upon my A plus B divided by C upon my C plus D. But I can easily neglect the A and C in front of B and D. So what I get now is A upon my B divided by C upon my D. Let me annotate it for you. Now you will get this A upon my divided by B whole term divided by C upon में D. Okay, and can I write it down as, I can take the D all the way upward, and I can also write it down like A into D divided by C into my B, right? So now you can see this is same term as that of the odds ratio. So for the rare disease assumption, or the diseases which are very rare in a certain population, my odds ratio are approximately equal to the relative risk. Okay, that's the rare disease assumption. Okay. So if the step 1 will ask you why, in a certain situation, the relative risk was equal to the odds ratio. And if the step 1 asks you why is this the case, because it is a rare disease assumption. Okay.
Okay.
Any more doubt on this page? Please ask. Anyone?
No.
No.
Someone is asking, HR is in between two treatments, relative risk ratio, right? I don't understand what you're trying to ask.
I mean to ask, is hazard ratio is something when we are putting two treatments, like two different treatment, either we are doing a surgery.
Yeah, let us suppose we have given a smoking to a certain number of group of patients. Okay. And now I want to calculate how much time it would take to develop the lung cancer when the smoking is given to a certain patients. So this would be calculated by the hazard ratio. Okay.
I mean, like if we are giving, if we are, suppose we are treating some cancer cases, and then we are treating with some two type of different regimen of drug like chemotherapy. So in between, we are trying to analyze the hazard ratio, because hazard is something like how is the outcome difference between these two drugs which we are is it something?
Exactly. Yeah, of course.
So it is something relative risk ratio in between two treatment.
It is related to a risk.
Relative
I'm not
risk
sure
ratio.
what. Yeah, exactly. Of course. The risk in the, the risk in the exposure A by the risk in the exposure B, you are asking, like, okay, right?
Yeah.
Okay, so see, in this scenario that that we have discussed in before, we have the intervention or we do not have the intervention, right? Before, but it can also be like an intervention A and an intervention B. It can be same, right?
Yeah.
So it could be intervention A or intervention B, and I get the disease or I do not get the disease. So, and as the same way, I can write it down here also. So, okay, it could be intervention A and it could be intervention B. The risk in the intervention A and the risk in the intervention B. Both things are true, okay?
Yeah, thank you. Thank you very much.
Okay, guys, any more doubt?
No.
No,
Okay, I think we should wind up here for now. Okay.
Okay.
Guys, thank you so much. I hope you are able to understand what we have discussed in the biostats till now.
Yes. Thank you.
Thank you.
Thank you, everyone.
You upload yesterday lecture.
Yeah, I will upload both the lectures soon. Okay. After the lectures, don't worry.
Thank you.